demanding awareness and attention. A mere glance at the credentials of our esteemed guest speakers ensures that we are in for a real academic treat. And we hope that this conference will be a fruitful and enriching experience for all those who have come here to attend. We are happy to have our chief guest for today as Professor Manzoor Ahmed, the Honorable Vice Chancellor, Swami Vivekananda Subharti University. We are also delighted to have with us.
At the outset, may I express our warm greetings and welcome to Dr. Manzoor Ahmed, Honorable Vice Chancellor of Swami Vivekananda Subharti University, Meerut, for gracefully accepting our invitation to inaugurate this conference despite his busy schedule at an extremely very short notice. I still know that he had prior commitments, but he did as a great honor by coming here this morning. I also extend my greetings to Dr. Shalya, who unfortunately at the last minute had some commitments and could not come here as an honorable guest. Dr. Atul Bhatnagar, former president and the founders, and Dr. Bhatnagar, both of them have sent their greetings and well wishes to the conference, and they also could not attend. Guests, faculty, though many of them have not reached here due to the weather problems, and they all will be reaching in a short time. We have some of the most academically excellent speakers. Dr. Rajesh Nagpal, who is also the IAPP president of the parent body. He was supposed to be here. I'm sure he's head up on traffic. Dr. Venugopal Jhamar, Dr. Prabhat Chitole, Dr. Ravi Gupta, Dr. M.S. Bhatia. These are all doyens, well-known figures in the academic world of psychiatry. In addition to this, we have decided to felicitate some of the doyens and our elder psychiatrists who are going to be felicitated a little later. We will welcome you all, sir, for being with us. We also extend our greetings and welcome to our dear colleagues, faculty members of the college who have been very kind enough to honor us on this occasion. We welcome all delegates and other dignitaries, postgraduate students who have taken time off to be with us, and I hope they will benefit from some of the topics which are being discussed here, as mentioned, neglected issues in psychiatry. I extend a warm welcome to the members of the press and media. May I take a minute to explain and give you a brief outline of our department. This department was established in the year 2004 with 25 beds. It has grown rapidly, and we had our first postgraduate student admitted in 2011. It has grown rapidly in the last 6-7 years. And now, this year we've been allotted 3 seats. 3 of our postgraduates have successfully completed their course, and they're doing well, and 2 of the last candidates are employed here as senior residents. We are 6 psychiatrists with me, Professor Chowdhury, 2 assistant professors, Dr. Supriya Vaish and Dr. Satish Bhutania, 2 senior residents, Dr. Priyanka Sharma and Dr. Anubhav Dua. We have 3 clinical psychologists, Mrs. Vasudha Singh, Dr. S.P. Bharati and Ms. Seema. We have 2 social workers, medical psychiatric social workers, Mr. Sonu and Mr. Vijender. We have an occupational therapist, Mr. Vijender, and 7 postgraduate students. We have an outpatient attendance of 80 to 100, which caters to the surrounding areas of Meerut as well as Meerut. And this is a pretty large clientele. Our bed occupancy is 80 to 90, and today we have 100% occupancy. It only indicates that there is sufficient work, and we are trying to do our best to give good medical care to the clients. We run specialty clinics in child and adolescent psychiatry. In fact, Dr. Chowdhury is trained in child and adolescent psychiatry, geriatric psychiatry, sexual disorders, de-addiction clinics. We have a well-established de-addiction center. Besides this, we impart regular training to our MBBS students and internship. We also provide training to nursing students, physiotherapy students, dental students, and also we organize outreach programs. We have been having workshops frequently. We send out our postgraduates to attend various conferences and CMAs. And I also take this opportunity to announce that we propose to establish a gold medal for any student in MDU passes out with distinction in the name of one of the fathers of Indian psychiatry who is known as father of Indian psychiatry, Dr. Vidya Sagar. We have just recently approached the family for their permission, and as soon as we raise a corpus, we hope to institute this medal. It will be a great amount of encouragement to our postgraduate residents.
Request Dr. C.P. Madhesha, Secretary IAPP UP chapter, a renowned psychiatrist from Gorakhpur, to kindly occupy his place. I request you to kindly conduct this session.
Indian Association of Private Psychiatry, Chairperson Indian Association of Biological Psychiatry, Director Behavioral and Neuroscience Academy of India, and President of Society for Bio.
And thank you, Chairperson, for your very kind introduction. My topic is boundaries in psychiatric practice. And IAPP will bear with me. We have had several issues in these two particular areas. The Mental Health Act, which is now the draft act, which is now in the Rajya Sabha, has been made as a part. The core group making it was part of what is called critical psychiatry, and the people who were opposing our point of view were post psychiatry, and I'll tell you what that means. And that is why we have run into serious problems. That means that professionals who see 100 patients a day, professionals who see patients night and day, making sexual advances, complaints being sent to the dean and the authorities and no action taken, is appropriate professional conduct. And the definition is highly context dependent. It may emerge from role issues, being materialistic, directive, time issues, place and space, money, gifts and services. For example, somebody, a property dealer, has a lovely property, a share broker who knows what share to buy, clothing, luggage, language, and physical and sexual. Find as a transient, non-exploitative deviation from classical therapeutic practice or general practice, what I and you do, in which the treated steps out to a minor degree from a strict verbal psychotherapy. These boundary crossings do not hurt the therapy and may sometimes even help it, answering select personal questions. For example, what I had last night, what my son is doing, may sometimes be answered. Boundary violations constitute essentially harmful deviations from the normal parameters of treatment deviations that do harm the patient, usually to some kind of exploitation, and which breaks the rule. Hippocrates, first do no harm. Taking advantage of the patient financially, I mentioned the share market, speculation, gambling, racehorsing, whatever. Using the patient to gratify our own dependency needs for menial services, like cleaning our cars because he is having gradation, and he wants a small job, getting lunch for us from our home which is close by, running errands for the therapist, or engaging sexual or sexualized relation with the patient. For example, patting this young girl on her back inappropriately, in the process of seeing for pallor, touching her cheeks. So how do we distinguish between a crossing from a violation? Possibly a crossing and not a violation. An even better test is, can the behavior in there is also a principle of fiduciary, the Hippocratic Oath we are all familiar with, the trust issues we are very familiar about that. The doctor as a fiduciary, as a legal term, owes a duty to the patient to place the ladders in targeting the patient need is a primary duty. Not what I think might be his need, but what his actual needs are. Exploitative boundary violations are viewed as breaches of the doctor's fiduciary duty to the patient. The treater has placed his or her own gratification ahead of the patient's needs. So you prioritize your needs prior to the patient's needs. That's a violation of fiduciary. Now, therapeutic boundaries are not ironclad boundaries. They are not cement boundaries. The treatment modality, the context of care, and the development of the patient, for example, a very young patient, can influence boundary and can influence boundaries. Psychiatrist who handles the medication of bipolar patient, cared for by a large team in a large hospital, will attach a different meaning to a gift of a homemade cake than to the psychotherapist who has worked with the patient for several years. A graceful thank you may be the ethical appropriate response for the bipolar patient, and the cake will hopefully be shared with everybody. But the psychotherapist declining the gift and introducing the interaction into the therapeutic work, for example, raise the issue of transference, would be the clinical and ethical imperative. So it's not the act, it is the context also which is extremely important. Boundaries are also influenced by when a psychiatrist and patient are overlapping boundaries. See, many of us are members of IMA and IPS and IPP. Some of us are members of Lions Club and IPS and IPP. Some of us are members of our society in which we stay. The caregiving psychiatrist is also family member sometimes. A friend, a neighbor or colleague, as is common in small communities like a mohalla. There is a greater risk of real or perceived boundary transgressions because there are multiple expectations and needs existing in such situation. For example, my neighbor, I live in a small area in Delhi, and my neighbor upstairs once asked me to come and see him. I said, there's a home visit, come to my clinic which is about 4 miles away. He was very angry. But we have to draw these kind of lines to work with them. And he was having a manic illness at that time. But there are certain caveats or axioms on boundaries. A member of the treatment diet is me and the patient, has a professional code to honor or to violate. So only I as a doctor am bound by the Hippocratic Oath. Thus only the professional is responsible for setting and maintaining professional boundaries. So it is I who am responsible to set and maintain of this diet. That's the unequal situation. Patients having no professional code may transgress or attempt to transgress by offering flowers or gifts or expensive perfumes, professional boundaries. If they are complete adults, they are responsible or accountable for their behavior. However, it is for us to hold the line, to tell about the transgression and point it out. About 4 years ago, a young patient of mine, she was a diamond trader, asked me to have a cup of coffee with her outside to discuss a very important issue. And I declined, and I told her why. I talked to a brother who was on the phone that I I think this extremely interaction between the therapist and patient is neither to blame the victim, that's the patient. We try and understand it and try and work around it, because that's part of our work, part of our life work. There was a study by Gabar 89 which profiled 3 kinds of people who do this kind of violations, talking primarily of the sexual violations. Smallest group consists of psychotic individuals whose behavior is affected by delusional thoughts. Am I audible, sir? Second larger group display antisocial characteristics and have engaged exploitative behavior in many relationships. For example, antisocial personality disorder, borderlines, we have a long history of that issue. The third group and the largest is what I have encountered in my clinical practice also. I'm sure many of my seniors have also done that. Is comprised of neurotic or character disorder individuals who are susceptible in the state of themselves. Sometimes happens with a young intern in a psychiatric school and falls in love with the older patient in seeking to restore mental health. That makes us special. The kind of impulsive and self-destructive behavior of a traumatized person, traumatized by road accident or whatever. Intermittent but severe symptoms of an unemployed adult with bipolar disorder. A family coping with addiction, so common today. Patient with schizophrenia who starves himself because of fear of poison food. These situations arouse immense effect within us. We learn of their intimate lives and we are often vulnerable because of their illness and life situation. We routinely encounter ethical complexities in caring for patients with mental illness. Unfortunately, we are held to the highest level of accountability in ethical practice. As doctors, the community expects us to never do any harm. Now, concern and a major reason for complaint, for litigation and deregistration worldwide. So sexual misconduct has of course occupied prima donna position there. In North America and Australia, it is estimated that 7 to 10 deregistration. Some of us who have seen Patch Williams, Robin Williams, Patch Adams, Robin Williams, who died of depression, who testified what we saw in the medical school there. There is a concept called the slippery slope. A number of studies have clearly said that sexual exploitation causes destructive effects. Such misconduct almost invariably begins. These are part of psychological autopsies made. Begin in an app, an SMS late at night, if not recognized and dealt with, can proceed inexorably from the harmless. Some of us argue that are not a group apart from the rest of us, but rather more like than unlike the rest of us. They are quite like us. Unfortunately, nobody is exempt. Somewhere in the complex interaction between psychiatrist and patient, a series of events unfold and lead to abuse. All of us sitting here, including myself, need to be mindful, overwhelmed, incompetent, afraid, guilty, angry, or frustrated will be labeled difficult. Patients with unexplained physical has that profile. So how do you manage such patients therapeutically? There are several tactics I suggest. One is understand yourself, the familiar Rouhani safar. Be aware of your own biases, your prejudices and counter-transference. I had a friend of mine, a second friend of mine, understand why certain types of patients upset you. Realize you are not a bad doctor. You are negativizing some patients. We also need to understand the patient. Every difficult behavior, and we saw that in children, that the crying, the temper tantrums, all have meanings, is a form of communication. every difficult patient is trying to express real fears and needs. Evaluate your patient from the Mavian biopsychosocial model, not just the mechanistic view. Reflect and think, do not react. We often talk about this anger management to our patients. Every difficult behavior is a form of communication. Every difficult patient has to express his real fears and needs, and go back to evaluating from the Mavian model. Now, what are the consequences of a boundary problem? The intrinsic consequences are, it may doom the therapy and may cause the patient to feel betrayed and used. The clinical consequence of boundary violation, including sexual misconduct, may encompass the entire spectrum from emotional harms, from mild and transient distress to complete suicide. The extrinsic ones worry us. The civil lawsuits, complaints to the board registration, Delhi it is the DMC and the state FHA. In the future it will become the Review Mental Health Commission, which will come to force. Ethics complaint to the IPS or IAPP. Peer review committees have not yet been established except on paper. Now I shift focus from here to boundaries of psychiatric disorders. I make a conscious decision here based on my limited experience in the last 3-4 years. Whenever any debate heard on mental act, the new act, you are one kind of people who say, nobody understands us, we are doctors, we know patients best. We know exactly what he wants. Then somebody says, why a law? Why only law? Why only a law for us? Why not for the cardiologist? Why not for the nephrologist? Why a special law for us? And somebody says, I don't believe all these NGOs. They are nothing. Things have changed. I wish to bring to you a new perspective. Study from UK NHS data, the number of beds are at the same time. Occurring because the boundaries of psychiatric illnesses are broadening. And the level, especially in the US and now in India, for a large number of children, just because we cannot spend time with our children as much. Our schools have large number of people who they have to control and teach like on a conveyor belt. And now we have the adult conditions for which they are not indicated at all. So saying that they heard voices, in fact they did not hear voices, and were discharged on the third or second day when they said they stopped hearing voices, but with the label of schizophrenia, 6 to 357 in 4 days. All these diagnoses to teach and there are to talk about. Psychiatry is a medical science, stick to the medical science. It's a branch of medicine, treats people who are sick and needs treatment, mental illness. There is a boundary between who is normal and who is sick. You should codify the diagnosis. And then came Mayer. And Mayer proposed what is today closely true to our heart. That the boundary between SARS and Lang, who came from psychiatry, criticized psychiatry, it has been working, we shall come out with a policy statement. Right now it's only a draft statement. So we don't have a comprehensive statement, but there is some inkling that it might come. Engelby, Foucault, who are psychiatrists, who share the same vision as us, but who think slightly differently. In the Mental Health Act, people like Dr. Alok Sareen, Dr. Soumitra Pathare, and others who have not told our line are the critical psychiatric people. And their contention is very simple. This is by Bottom's contention. This is by Bracker and Thomas. Psychiatry is based on a set of assumptions about the nature of mind, meaning and knowledge, and the distress. This means paying more attention to the different ways in which the service users, and we today need to focus on the patient as a person. Patient-centric, person-centered approach, which emphasizes the uncertainty of psychiatric practice. I now close with one small invitation with permission of the chair. 25th, we are having the Global Conference on Balanced Psychiatry, 25th to 28th September at the JW Marriott in New Delhi at the Aero City. is going to showcase people most of us have only heard of. John Kane, clozapine, Siegfried Casper for his famous trials on drugs. We're going to have Jin Mali, we're going to have Rajiv Tandon there, we're going to have Machiri Keshavan there, we're going to have Florence Tibu. 25 international delegates, the best of athletes in the world is coming there for a 4-day scientific feast. We have no gala dinners, box lunches, science from morning to evening at a very cheap registration fee. Today, anybody want to join today, I will give the registrations and the rate it started on, it is 7,500 rupees for all who can join today for this meeting. Please come there. Thank you very much.
Thank you, sir. It was a very interesting talk on a very clinically relevant topic, psychiatry, on question answers.
This session is for the any question?
Is this whole psychiatry movement is limited to lots of programs on TV, someone claiming a total relief from joint pains, nothing. Then we too are responsible for this type. You must be seeing in papers, columns, where non-psychiatric problems are being discussed by a psychiatrist and providing a solution which is nothing to do with the psychiatric practice. Well, psychiatrists, they get involved with their patients. Is there any comparative data with other disciplines?
No, sir. No, sir. I don't have the data.
Dr. Rajesh Nagman. He has touched upon the subject which was very dear to us. We were not knowing as to what to do about it. It is coming in the media and press. It is taken into two parts. As far as the first part is concerned, many things has been told, but most pertinent is the involvement with sexuality, both on the part of the therapist as well as of the patient. When the patient develops transference from the therapist, it becomes a really very painful, ugly situation, unpleasant situation. At the same time, when the therapist and when we meet them, this is a part of human weakness. How far we are concerned as far as labeling it to the crossing the boundary, well, it has been well spoken by him. As regard to your second part of the talk, yes, it's very advancement in the psychopharmacology. The various molecules which have been brought about has turned the total scenario as far as the relief provided by the mental health professional, especially in the psychiatric practice, by use of the psychopharmacology agent. To that extent, that all the other fraternities frequently, your anxiety, your antidepressant. So the psychopharmacological advancements, it doesn't only provide the relief to the patients and the suffering, but at the same time, it explains you the phenomena. It gives and provides you the biological basis of the disorders and explains you the phenomena of the brain as to how the brain functions, where the things goes wrong, neurotransmitters, neurotransmitters. So as far as I hope, the legal issues are there, but still we have got to go in a very confident way to profess our profession and stick to it, and ultimately we will see a day of the night when people will realize that psychiatry is not simply a slogan mongering, but it is a very pragmatic and objective subject. Thank you.
It was a very pleasant and very good presentation, but I am afraid I have to confess that by the end of the presentation, I was confused. At one side you say that we should treat these people, and when you talk of critical psychiatry, you say that we, as rightly pointed out, we have seen the positive effects of the newer molecules and how they effective in reducing the critical psychiatry. The anti-psychotic movement has been going on for such a long time, and we don't think that psychiatry that is not
Fully agree with what you are saying. I'm going to point out a reality which is existing today. We are now, our power is only in vacuum today. We do not have the same power as we used to.
Just one last question.
Sir, thank you. Then why only there is a law for the psychiatrist? Almost every medical practitioner is dealing with emotional problems of the patient in some or the other manner.
This has been a subject of debate several times, but I have patients in those who could not give consent. So this particular category, which affects about, say, severe mental illness, is about 7% of our entire population of mentally ill. It's a large chunk. Some of them cannot give consent at some point in time for some time. For them, you have to have a special law. Hence, the Mental Health Care Act today, if you read carefully the new one, it's regulating basically that particular category. It is not regulating the establishments providing psychiatric services. It is not regulating the anxiety and the OCDs and the minor depressions. That category which deserves admission, which would in some cases be involuntary, falls in the particular realm where you will license the establishment. If I or you run a psychiatric OPD and offer services OPD, we are not governed by the Act until we admit a patient there. I hope I am clear in this regard.
Thank you, sir, for a talk, and thanks to the audience for an interactive session. Now over to the organizers.
Thank you, ma'am.
DBS, that is a that's an effective treatment. At least 35 to 40% patient respond very satisfactorily. So we have several studies with the DBS. We do cingulotomy, we do capsulotomy, and then we do subacute tracheotomy. These are the neurosurgery criteria. Basically, 5 years of OCD with at least 1.5 years with impaired quality of life of treatment refractory OCD, unless and until that. And patient has taken in last 3 months minimum 20 years of behavior therapy. Now for neurosurgery for OCD, you have to go for, it's something like when you do for renal transplant, you again have to go for two independent opinions. This is about capsulotomy. It is effective in reducing OCD symptoms. There is substantial risk of adverse effect, and the risk may vary between surgical methods. Our findings suggest that small lesions are safer than high radiation doses, and multiple procedures should be avoided. I'll skip this slide. Can imaging help predict treatment efficacy? This is something very important. Because days are not for you will have PET and SPECT in almost all tier 2 and tier 1 cities almost have that, tier 2 cities also. But will it help you clinically? Unless and until you are assured or you have significant confidence of interpretation and proving your point, I don't think it will have clinical relevance, at least for few years to come. Behavioral therapies in terms of neuroanatomical alterations is one of the biggest evidence which we have come across. This is the PET scans of OCD patient. The pre-drug treatment you can easily see. OCD pre-behavior, this is the post-drug. You can see the red signals going away here also. Psychotherapy effects in OCD. We have significant studies of CBT effects in OCD were consistent in showing decreased metabolism in the round caudate nucleus. Same study with this proton MRSI study. Same continuation with the drug citalopram. Significant difference between patients with OCD and comparison subjects. This is comparing citalopram with drug-naive patients. What actually is to be done, basically the whole theory behind psychosurgery is destroy the connection with the frontal lobe and the basal ganglia limbic structures. That was basically the crux of psychosurgery. 27% definitive improvement, 27% probable. So that's a large number. Almost 50% of them they improve. 46% no improvement. And the other study says 32% definite improvement, 14% partial, and 54% improvement. So roughly we can say 50% of patient improved considerably. This is about the DBS. It's simple. We put an electrode here, and then it's like a battery operated which gives a signal, and there is a continuous firing. Genetics of OCD is exactly like biting more than what we can chew. So probably I think in this forum I think it will become too less time. So I think just highest symptom is obsession and checking, symmetry ordering, mother-child correlation, candidate gene, the glutamate transporter gene. This is interesting. Now we started with positives, negative, affective, then came cognitive, then came the movement disorder symptoms, all in schizophrenia. They came and coming. Now I see this trend coming in almost all the major psychiatric disorders. So there is a shift from motor to cognitive spectrum. It was initially compulsions, which you could see in Tourette's, tics. So ultimately localization was a put up menu. Now we see obsession, panic at the ideation level, and we see from cognitive. So probably we are basically here to. This is a circuit for repetitive behavior. This is basically a Brazilian study with some of the Greek collaborations. This is one slide to show that basically multiple pathways of OCD, multiple causing factors. One of them is autoimmune, which is seen pandas. Immediately after the streptococcal infection in children, we see various OCD symptoms, with tics and other things. So I think clinically the take home would be we need to have a reasonable knowledge of neurobiology, especially. Thank you.
Uncommon topic, and he has covered very comprehensively. Now, subject is open for the discussion.
Okay. You, Dr. Jhamar, you started your topic with this OCD spectrum disorder. In late 70s, this word was, we did not hear this word. Oh, sorry, I was misheard. I did not hear this word in late 70s. And incidentally, during those days, SSRIs were not available. In 70s, and incidentally, second generation antipsychotics were not available. Today also, in my small 35 years of psychiatric practice, I have not seen a single patient in first visit untreated presenting OCD with schizophrenic symptoms or schizophrenia with OCD. One must think about it, why this change has occurred. Why there were no obsessive symptoms in schizophrenia earlier, and why there were no schizophrenic symptoms in OCD earlier. And now with the advent of second generation antipsychotics and SSRIs, we are having obsessive spectrum disorder. These may not, it is possible that first generation antipsychotics being dopamine antagonist for protecting from developing OCD symptoms, as we have mentioned, that dopamine agonist exacerbate the incidence of OCD symptoms. So is it not that these symptoms are hydrogen?
Sir, I think you raised about two diseases. One, there are actually several ways to look at this, and I think it cannot be looked at one way. What you say is correct, because it cannot be a time-based model, because if it was not there earlier, now it is here. There are many things which are not in the past, now they are here. I think better understanding may have been able to diagnose us better. There is certainly what you say, I respect that in your practice you did not see a patient, a drug-naive patient.
I stand to correction.
Yeah. So that
Relations more likely to be liked by their teachers and perform better in a school. They are also more resilient in face of stress or adversity as preschoolers and later on. On the other hand, children with insecure child-parent relationship are more likely to have adverse outcomes. And factors that affect child-parent relationship very strongly influence emotional functioning of a child. Through child-parent relationship, the child, here, infant and toddler, they learn to socialize with the external world and develop a sense of competence and self-worth. A secure child-parent relationship buffers the external and internal risk factors. For example, poverty, which is an external risk factor, and difficult temperament, which is an internal risk factor. A secure child-parent relationship protects the child against them and buffers them. Therefore, in order to assess, understand, and treat a child's psychopathology, it makes sense to assess child-parent relationship. Now, a comprehensive assessment should be done. The settings in which this assessment is to be carried out should be child and parent friendly, with child-sized furniture, toys, picture books, and parenting related literature. Parent and child should feel comfortable and welcome. The clinician should develop a rapport with the parent. The assessment of infants and toddlers is basically observing and eliciting information about the child, parent, and the child-parent relationship. And this is done while the child is with the parent, it is playing, doing a task, or undergoing a stressful situation and coping with it. The stress is used as a means to assess the child's mental state, the child's psychology, and the strength of child-parent relationship. While all this is happening, the mother is minding, taking care of, and playing with the child. She is comforting the child when it is in distress. The above could be done in an unstructured or in a structured manner. One could use standardized assessments like rating scales or checklists or interviews. Now, when the child and mother are together and their child is playing, what if the child begs of the parent for his help, joy sharing, comfort, or using the still face method? Let me explain this. In your clinic, the mother and child are together and the child is playing with the mother, and when the toys or things are kept there, you ask the mother to go out and be not visible to the child. So absence of mother, the child's inability to see the mother is stressful for the child. There is something which you are experimentally producing. And then you can observe how the child is coping with it and what happens when the mother returns and is reunited with the child. In still face method, which is used for very young infants, say up to 3 months of age, the technique is like this. Now you know that infants look very intently at their mother's face, and in response to mother's face and a smile, the infant also smiles back. So the mother's face, the mother's smiling face is very reassuring and comforting for the young infant. Now the mother is asked to keep her face still, devoid of any facial expression, not smile. So when the infant finds that the mother is not reacting, she is not doing anything, she is not smiling, then this is stressful for a 3 months old infant. Mother does it only for say a couple of minutes, and you observe the infant's reactions to it. What information is to be gathered from the parent? This is anticipation, and with verbal children, shared representational play themes. The tone of interaction during the stress that we have produced experimentally. In addition to the above, you will take a detailed psychiatric history, medical history, developmental and personal history, family and social history, and a physical assessment needs to be done, whether you do it yourself or you obtain information in this regard from the child's pediatrician. Some tools could be used for assessing infants and toddlers, and the first is child-parent interview, which can be obtained from the website of Infant Institute, and there could be diagnostic interviews like preschool age psychiatric interview, or there could be diagnostic infant and preschool assessment, which is applicable from ages 9 months to 6 years, and you can assess the development of the child in various domains by using an equipment by a tool called Ages and Stages questionnaire, which is applicable from 6 months to 60 months, that is 5 years, and can be obtained from the place 18 months and above. After making your assessment, you discuss your findings with the mother or with the parent, and you find out what psychopathology is present, and you discuss that too with the mother, and it is possible that a diagnosis may be present, or it is possible that a diagnosis may not be present because the classification of infants and toddlers is not perfect both in ICD-10 or in DSM-5. So if psychopathology is present, you discuss that with the mother, and you also discuss how this can be corrected by modulating, by modifying the child-parent relationship. Next we come to preschool child assessment. Here again special techniques are needed for his adaptive and emotional functioning. Caregiver and child observation and assessment. Like this is similar to what you were doing in the previous stage with infants. Now, mental status of preschool children must be done and conducted in the context of play in multiple sessions and with multiple caregivers over a period of time. Infant and preschool mental health clinics format, and this format has got 4 50-minute sessions which are conducted over 4 consecutive. In the first week, a comprehensive standard psychiatric history, a detailed history of the preschool child's play, and you carry out diegetic free play assessment and mental, and the clinician already knows what the problem is from the mother or from the caregiver, and he should also know that the child will get to play with the caregiver the way he or she wants and the way he plays at home. Clinician remains a participant observer in this play and plays only if bid, that is invited by the preschool child. Children often do that. Clinician follows the lead given by the preschool child but never takes the lead himself. He is spontaneous and playful. He asks what is being played and how. That's how he connects with the child. And here again, a brief separation is enacted and the clinician observes the preschool child's reactions and coping during the separation and subsequent reunion. In the third week, we do semi-structured diegetic play assessment and mental status examination too. Here the diet, that is the mother and the child. I hope I am audible in the back. Is it all right? Okay. Here the diet is observed sharing a snack
You can give them something to eat. The mother could bring it on her own. And then after they do that, they do a cleaning up and then perform a mildly stressful cognitive task. Say for example, making blog designs from sample cards under time pressure. You have to make a certain design within a time limit, so which may be stressful for the preschool child. And then undergoing a brief separation, coping with it, and reacting on subsequent reunion and during free play. You observe children during these times. Now, interpretation of all this is important. A knowledge of child development is therefore essential. For example, sensory motor play, which is, say, shaking a rattle, enjoying the sound. This is sensory motor play, which a young infant would do. Or say playing with the cubes, banging them together. Or as they grow older, a simple symbolic or representational play. Like the child picks up an empty cup and pretends that it is drinking from it. Or such plays could become more evolved and more complex as the age increases. Say for example, the child uses the cup and makes up a tea party, and he plays with that. So as the age increases, the child's play also becomes more complex and advanced and developed. The 4-year-old child may attribute human qualities to other organisms and living qualities to non-living. All this could be observed during the child's play. The preschool child is egocentric. He sees the world from his point of view, like I am seeing you from here, but I am unable to understand that you are also seeing me. So, preschool child is able to see the world from his perspective, from his point of view, but not from that of others. Now, why this play is important? Delayed play scales may mean cognitive and/or social or reciprocal deficits or emotional problems. For example, if the child is unable to play according to his age, then this will be because of the cognitive delay as in mental retardation. Or it could be a reciprocal or social problem or similarly emotional problem as can occur in autism. Now, one may think, why not ask the child directly how is he feeling, what his emotions and feelings are. But this is problematic. The child may lack the required understanding of what you are saying to him. He may not be able to comprehend fully your language, and he may not himself possess the language to be able to answer to you. And it often happens that the child may say yes when it wants to say no. Or the child may not say anything for the sake of punishment. He might say something wrong for which he will be punished later on. So a preschool child's emotions will be accessed indirectly during play. Say anything, but it may be say with dolls or puppets onto whom the emotions of the preschool child are transferred. Now in mental status examination, you note obvious things like general appearance and behavior, the child's cooperation, eye contact, social engagement, social referencing and social reciprocity, development of language, cognition, motor functions, speech, where you note articulation, prosody, rate, volume, echolalia, pronominal reversal, stammering. I mean, these are the things which are to be noted. Play and engagement with caregiver are also to be noted. And then again, like in the previous stage, you make a review of your findings, think of the diagnosis, make a biopsychosocial formulation, discuss these with the parent, and then you plan your treatment and tell that to the parent as to what can be done with this infant. Next we come to school age child's assessment. The clinicians here must know the normal psychosocial development in this age group and also the normal developmental deviations, because normal developmental deviations are different from psychopathology and from a psychiatric disorder. The main things to be considered here are assessment process and assessment content. Where the child has grown, he is able to be away from the mother or from the parent, he is able to play with other children, he is going to school, learning a number of things. And the assessment process should include the parents and all other caregivers, and the history should be obtained from them and from caregivers in the school, functioning in the family, social circle and with peers should be obtained, and you ought to be sensitive to cultural and environmental issues. The operational or the logistics aspects of this assessment. First of all, establish a collaborative relationship with the school-age child and with the family. This leads to mutual trust and understanding of This leads to mutual trust and an understanding of the current difficulties of the child. And this in turn helps with understanding of assessment process and sets the stage for acceptance of case formulation which you will make later on and your treatment planning. Inform the school-age child of times, what fees, what money you will charge, how long will be each session, so on and so forth. Inform the parents about the guidelines for assessment, the process to be followed, safety of the school-age child, and that they know most about their child and you would like to learn from them. This makes the parents feel important, and the child has been brought to you. The aim is letting you find out if the child has got any psychiatric disorder, but the real purpose is preventing expulsion from the school or getting the child promoted to the next class without clearing the examination. Such things can happen. Be sensitive to the cultural and environmental issues. Educate and reassure parents, and above all, do not make the parents feel judged and evaluated. Now, here is an outline of a school-age child assessment. As clinicians, you know all this, but I would like to draw your attention to some points here. And the first is assurance about a painless assessment. The child must know that assessment is going to be painless, so he can cooperate with you. And then whether there are any legal issues involved. These days, you know, there is a lot of child abuse and sex abuse, and the children could be referred to clinicians, psychiatrists for assessment. What is the impact of that abuse? So find out if there are any legal reasons for it. Find out the reasons for referral, the real motive. Find out why the child is being brought now, at this point in time. Then, as doctors, as clinicians, we are in habit of finding faults with people. What are their shortcomings? But it's important that you find out the strengths, interests, and assets of the child, and also of the family. Because if you do that, this can be used later on in both in biopsychosocial formulation and in treatment planning. Trauma history is again important. Has there been a traumatic event? Has there been a physical or sexual abuse? You could ask the child, has anyone ever hurt you and you were afraid to tell your parents about it? Has anything ever happened to you that really frightened you? These are the things which can guide you to make you think, has there been a problem of that kind? And then you must carry out a psychiatric review of symptoms. And by this I mean that children have multiple comorbidities. So say for example a child might be brought to you say for mental retardation or for ADHD. But I would suggest that you systematically assess all psychopathology, review all symptoms, because say in ADHD, say 60 to 80% of ADHD children would be having another comorbid psychiatric disorder. You would do a mental status examination, you would do a risk assessment as well, related to self-harm, suicide, harm to others, homicide. Ask the school-age child and the parent about the school-age child's concept of death. A biopsychosocial formulation should be made. You will make a differential diagnosis and you will make a multi-axial diagnosis which will be in psychiatric, physical, psychosocial realms and the impairment which these symptoms or disorders are giving rise to. Then treatment planning, the treatment targets may be school-age child's psychiatric symptoms, the distress or dysfunction caused by them, the developmental issues, the child is not developing properly, medical issues, family systems issues, and community and cultural issues. These treatment targets need to be prioritized on the basis of equity and operational aspects or logistics. You may be required to prognosticate what are the child's symptoms and problems and what will happen if they go untreated, what will happen if the child is properly treated, and further evaluation if it is required by you or by somebody else. Mental status examination has the usual headings. I have added hallucinations here. Although in 6 to 12 years of age, hallucinations and delusions are rare, but nevertheless, the parent and child's versions may be different. The child may say depression. It is possible that the child suffers from them, he knows about them, and the parents have not been able to observe it. And that is anxiety, but denies having conduct disorder, which is reported by his parents. So this is broad understanding. And you could use standardized semi-structured diagnostic instruments and rating scales. Certain disorders may require specific techniques or tools for assessment. Mental status examination for core features of ADHD has been described by me. One could use ADHD rating scale by Newport. One could use autism diagnostic interview device. All this is available from the Department of Psychiatry, KGMU. You may like to contact the head, Professor Dalal, or in charge of faculty in charge of psychiatry, Dr. Vivek Agarwal. Or one could use autism diagnostic observation schedule, generic, but this is not available with the Department of Psychiatry. One could use childhood autism rating scale. This again is available in the department. One could use modified checklist for autism in toddlers. You can access it from the net. And you could use any schedule for schizophrenia and affective disorders. And this is applicable from ages 6 to 18. And this is a standardized, semi-structured psychiatric review and diagnostic interview of past and present episodes in the child with impairment ratings, and the same instrument would be administered both to the parent and to the child, and this again is available in the Department of Psychiatry. You could use Conners rating scales revised, and the number of forms are available, and these are for child, parent, teacher, and there is for adolescent, there is a youth self-report. This again is available from the Department of Psychiatry. After having said that, I will again say that once you have made the diagnosis, you will discuss your diagnosis with the parent, talk about the treatment and such things. Next we come to adolescent psychiatric interview. Chairpersons, do I have time? All right. The purpose of adolescent psychiatric interview is development of rapport with adolescent, which is a very important task. Establish the possible diagnosis. Psychiatric interview is one of the several steps that need to be taken for full diagnostic process, providing initial therapeutic input to which more will be added subsequently, and creating a base for full and continuing therapeutic intervention. The interview setting and a style, needless to say that the setting should be comfortable, relaxed, and with some privacy. The interviewer should plan and enlist the tasks that should be accomplished during psychiatric assessment, but not be driven by them. There is evidence that adolescent motivation and resistance depends upon the interviewer's style. Say for example, interviewer's stuffiness leads to distance, arrogance to sarcasm, and authoritarianism to defiance. Confrontation increases resistance. Interviewer should not become passive, seductive, cognitive, arrogant, sarcastic, condescending, or one must not compete with the adolescent. Adolescents would expect interviewer to behave as a mature adult and keep some distance between him and themselves. Interviewer should be non-conflicted himself. He should not have issues of his own. He should be tactful, flexible, relaxed and informal, and with a sense of humor. That is an advantage. And he should be able to genuinely appreciate and praise positive aspects of the adolescent's behavior, because this will increase his cooperation, rapport, and motivation for assessment. And this should happen early in the interview. Interviewer should keep on summarizing and conveying his understanding to the adolescent frequently in the interview to increase rapport. Then operational aspects. Who should be seen first? The parents, the adolescent, or them together. The standard practice is to invite the adolescent first. This has the advantage of letting the adolescent know that he is being given due respect. His views are important for the psychiatrist, who may be impartial. And after you develop a rapport, you may ask about what the problem is and its causes. The disadvantage of seeing the adolescent first is that you lack the background details and the parental reasons for consultation. The parents may be seen second, and apart from gathering information, you have to tell the parents what the adolescent has said. Besides, one has to address the parental concerns themselves. Confidentiality is an important issue and must not be breached unless there is a risk of harm to the adolescent or to others. The parents or the adolescents may also be seen together. This has the advantage of observing their interaction, mutual concern and regard, and independence of views and behavior. And during the joint session, the problems and differences between the parents and adolescent will become very obvious. But direction is needed, lest the interview becomes chaotic. Later, the adolescent has got to be seen on his own. But it is not necessary to stick to this order. If the adolescent is hesitant, shy, the parents may be seen first, or else both you and the parent may be seen in a joint session, but then the parents speak first. Now, engagement of adolescent is the first task in the psychiatrist's role: cooperate or give reliable and consistent information. And without reliable information, neither diagnosis can be made nor treatment planned. But adolescents being appreciative of their strengths and positives. And by doing so, you are not talking about painful things, things which are painful things. And if this is so, it may be possible for the adolescent to answer your other questions and comment upon the issues that you raise. Is it a sports, adventure, socializing, money, religion? Seize the opportunity to talk about and engage him in a topic of his interest, and then praise and appreciate him for his efforts and skills. There is a role further as a psychiatrist who understands him and can help him. This leads to more data, better psychiatric understanding, and better treatment. If during the interview adolescent is mostly quiet, answering only yes or no, or I don't know, it means that he is not engaged. Efforts should then be made to increase his engagement and motivation for participation in the interview rather than continue to interview and elicit data. In the first interview, engagement is more important than data collection. After the adolescents are engaged, they need to be explained about the psychiatric interview. They should be told that the idea is not to find faults with them, but rather to discuss the problems from their perspective and to find solutions to these problems. To do this, psychiatrists will need to understand them and their life. And this can be done by talking about family, education, peer group, their work, and future, etc. Questions. What questions you will ask and how will you ask them? As is generally done, first broad-ended questions should be asked, followed by pointed questions. First, why the subject, a particular issue, is being raised should be explained to the adolescent. For example, in relation to studies, studies are important as they help you to achieve what you want in life. How about your studies? Which subjects you like best? Which are the difficult ones? Which is the most difficult? What sort of marks did you score in arithmetic? What is the most difficult thing with it? Asking about family and friends. Let us know who are there in your family. Their names, ages, education, work, in and out of home. Tell me about your mother. How is she to you? How do you get along with her? One could similarly ask about the peer group. Who are the people with whom you move around or you are friendly with? Describe your best friend to me. One can thus know about the adolescent's assessment of his friend's personality and their relationship and capacity for empathy. Intimacy and romance is something that you need to find out, especially in older adolescents, but this must be done very tactfully and you must be aware of the cultural norms. People can be very sensitive about sexual matters and you may not get candid or truthful answers. One could ask whether there is someone of either sex with whom the youth is close. If yes, then who is it? And what attracted the youth to him or to her? Is the youth's interest reciprocated by the other person? Has the relationship turned sexual? Has there been any abuse of some kind? Similarly, about substance abuse, one should routinely ask the youth smokes, drinks, or uses drugs illicitly, and if so, with what frequency, in what amounts, in what contexts, and with what consequences. One could know the values and ethics of an adolescent. You talk about some important persons and role models you can think of, and ask who would the adolescent like to emulate or follow and whom he would like to reject and why. Elements of data collection are all known to you. These are part of a standard psychiatric history. But screening for psychiatric disorders, comorbid disorders, is again something very important. Substance abuse is again something very important. Always ask about it. Always ask about suicidal, homicidal ideation, plan and intent. As I have said earlier, unstructured initial adolescent psychiatric interview is for making a connection with the adolescent, motivating him for further complete assessment, developing a rapport, finding out problems, and initial psychological treatment as provided by giving him hope, support, and an understanding. For further psychiatric assessment, you could use semi-structured interview case acts PL, to which I refer during the school age assessment of memory and intelligence should be done. Assessment with any other tools mentioned earlier for a school-age child will also be used for adolescents. And a few points about the differences from adults. If the adolescent's problem, say, is a mood disorder, or if it is a psychotic waited for the interview, and this requires the specialist skills. And rapport building also requires the specialist skills, and an understanding of adolescent psychodynamics helps in this. Friends, I have taken a lot of your time. There are some references after this, but we will not go into that. So I would like to end there. Thank you. Thank you very much.
Any questions? Any questions? Good morning, everyone. It's my proud privilege to introduce the first speaker, who will be speaking on diagnosis, evaluation and management of chronic insomnia. Dr. Ravi Gupta, and after seeing his biodata, certification examination for international schemes. At present, he is working as associate professor with the Himalayan Institute of Medical Sciences at Jolly-Grant, Dehradun, and he will be speaking on management, evaluation and diagnosis of chronic insomnia. Just an anecdote that, of course, insomnia is an important topic. We are talking about chronic insomnia, and I was talking about acute insomnia, where I am yet to get over the jet lag, because insomnia is yet to get over. So over to Dr. Ravi Gupta.
They are still sleeping, so I don't think the chronic insomnia is a problem, at least with the psychiatrist. But anyway, it's a major problem in the society. First come to the insomnia, whether it is important. Now this is a data from the study which was conducted by the WHO in 2002, when the report was published in 2004. This chart shows the disability adjusted life years with insomnia, and if you can see, India is also falling in a high rate of 60 to 70 disability adjusted life years only pertaining to the insomnia, beside all other. Now, one major problem is how do we define chronic insomnia? Systems ICD-10, DSM-4, DR, and the International Classification of Sleep Disorders, second version, they all were diagnosing insomnia with complaints of at least 1 month duration. But now these two classifications which have appeared recently in DSM-5 and the International Classification of Sleep Disorders, third edition, they clearly mention that chronic insomnia is a condition where the insomnia lasts for more than 3 months in a row. Moreover, ICSD goes even one step forward and says that if a person has suffered many episodes of insomnia in a year, and together if we can accumulate and they become more than 3 months, even then we can diagnose chronic insomnia, so that we do not neglect any case of awakenings or early morning awakening, or the person might complain non-refreshing sleep. So if a person qualifies any of these 4 criteria for more than 3 months, then it is D3, because the DSM-5 is more closer to the ICSD-3. It says a 30 minutes rule. That if a person after going to bed is not able to fall asleep within 30 minutes, that means his sleep onset latency of more than 30 minutes, or he has multiple nocturnal awakenings and spent a total time of more than 30 minutes awake in the bed, that means the wake after sleep onset is more than 30 minutes, or wakes up 30 minutes earlier than the usual wake time or the desired wake time. Then we say that the person is having difficulty in falling asleep, difficulty in staying asleep, or is having early morning awakening. Along with this, if a person says, even after 10 hours of sleep, the person says, look, doc, I don't feel fresh in the morning, I always feel tired. So we should not ignore it, it is a kind of insomnia. Along with this, the important part is person must have daytime symptoms. That means he must be having some kind of lethargy, fatigue, poor concentration, irritability, headache. So these symptoms must be present during the daytime. And this was done because we get a number of patients who have nighttime symptoms without daytime symptoms. Now the question is, should we diagnose it as insomnia? Should we prescribe them any kind of sleeping pill? Should we start any kind of non-pharmacological treatments? Now studies have shown that most of these people, they have sleep misperception. That means they fall asleep physiologically, but they are not able to actually appreciate that they were sleeping. So the daytime symptoms must be present along with the nighttime symptoms. Now coming to the evaluation, when we look at the evaluation of the insomnia case, especially the chronic insomnia, like any other disorder, we need to look at the history, the examination and the investigation. But the history is slightly different. Let's come to the history part. What should we ask? First of all, we should make sure that the person is having difficulty falling asleep, staying asleep, or even having early morning awakening. And we should ask about the sleep quality. How do you feel in the morning? Do you think or do you feel that you have slept well? Do you feel tired in the morning? Do you have any kind of urge to fall asleep again? Do you have difficulty in leaving the bed after getting up? So these kind of questions must be asked in different forms, because sometimes the patient may not answer to a single question regarding the sleep quality. So you must try to assess sleep quality different. Along with this, as the definition requires, you need the quantitative assessment. Now when we look at the recent, now this was a study by Charles Morini, one of the stalwarts in the insomnia. And this was published just recently, 2 months back. And if you see the table, you can see that the people who were good sleepers at the baseline, here, some of them developed insomnia symptoms, that means the insomnia complaints without daytime symptoms after 3 months. Some of them developed frank insomnia syndrome after 3 months. On the other hand, some of the patients who are having the insomnia symptoms, they repeated. They turn to the good sleepers after 3 months, and some of them developed insomnia symptoms after 3 months. And insomnia syndrome, the people from the insomnia syndrome also turn to the insomnia symptoms and good sleepers. So this shows that the complaints of the insomnia can vary in a year, given year. So the issue is, when we look at the insomnia, we must ask not about the past 1 month, but about a year, and we can go even backward. So we should try to assess the problem, the burden of the problem longitudinally as well. Now when we look at the course of the insomnia, this course may be a complete remission kind of course, it may be a progressive course, it may be a stable course where the symptoms appear at a given point of time and they are stable, they are neither worsening nor progressing. Or person might be having a repeating relapsing course with complete remission in between the different episodes, or might be having a relapsing remitting course with incomplete remission. That means the insomnia symptoms can be present in between the course. So when we take the history, we should ask about the course of the insomnia, because this guides us regarding the treatment. Always remember, friends, the treatment for the insomnia is just not a sleeping pill. Non-pharmacological treatment for the insomnia, especially chronic insomnia, is more important. So unless we have a proper idea about the course of the illness, we cannot plan any kind of treatment. Now, this was another study which was published in American Journal of Psychiatry in 2008, and it mentions that even the people with chronic insomnia, they have night-to-night variability. For example, they may be sleeping well on 2 nights a week, but may be having symptoms 5 nights a week or 4 nights a week. So, when the patient comes to us, we should ask, what do you do in the night? And we should ask about the given insomnia fall asleep, or how frequently do you try to bed, the time to fall asleep that a person takes after going to bed, factors which he thinks that they prolong sleep onset, factors which he thinks that they improve the sleep and he is able to fall asleep easily, then amount of sleep obtained each night. Now again, these factors are important. For example, a person comes to you that, look, I have difficulty falling asleep. And you ask him and he says, look, I go to bed around 1 in the night. But when I go to bed at 11 in the night, I have difficulty falling asleep and I'm not able to fall asleep till 2 hours. And I usually wake up at around 7 in the morning and I feel fresh. But still 3 nights a week I go to bed at around 10 because I finish all my work. And I am not able to fall asleep for almost 3 hours. So if you look at this situation from the insomnia point of view, he is having increased sleep latency. So he qualifies for the diagnosis of insomnia. But on the other hand, if you look at the usual bedtime, it is somewhere around 1. So his biological clock is set to fall asleep at around 1. And the problem is he is going to bed at an earlier bedtime. That frustrates him when he is not able to fall asleep for 1 hour or 2 hours and he comes with complaints of insomnia. Unfortunately, we get many of these patients who prescribe benzodiazepines or any other kind of sleeping pills. So when we are talking about a given night, we must also focus on the awakening. For example, a person says, look, I wake up around 5 times in a night, but I say I have addiction. Now we should ask about the associated symptoms. Why does he wake up? Does he have any kind of bad dreams? Does he have any kind of other problem? For example, going to washroom repeatedly. Because these kind of associated symptoms, they can give us an idea about the problem. For example, a person, elderly person who comes to you and says, look, I am not sleeping well and I go to washroom around 5 times a night. So this gives an idea that he might be having a BPH or might be a diabetic person or might be suffering from any other cardiac problem or might be on diuretics which were being prescribed in the night. So we can manipulate the existing treatment and we can explain the patient regarding the illness. So we should ask about the associated behavior. Many of these patients, when they wake up in the night, they start smoking, they chew tobacco, they start watching TV, or some of them they make tea and drink it, they make coffee, they drink it. So all kinds of these behaviors, these all are stimulants which take away the sleep. Now the problem is once a person wakes up in the night and consumes any kind of stimulants, the chances of falling asleep are again bigger. So we have to prohibit these kind of associated behaviors. So we should ask about the associated behaviors and we should always ask about the final awakening versus time out of bed. That means the wake after sleep offset. For example, a person says that I wake up at around 5 in the morning but I am not able to get out of the bed till 7. That means he is having poor sleep quality. Some of these patients say that they have a kind of light sleep where they go to sleep and they come back and they again fall asleep for 5 or 10 minutes and they finally leave the bed at around 7 in the morning. So this shows the poor sleep quality and such kind of patients are usually having some other kind of sleep disorders which we have to look at. Similarly, we should ask about the pre-bed conditions. What do you do when you go to bed? So do you watch TV? Friends, always remember the kind of damage the laptops, TV and tablets have done to the sleep, nobody else can. Excuse me. All these devices, they emit the light which falls into the blue light range, the blue spectrum. And the blue spectrum suppresses the release of melatonin. And all of you know that melatonin is a hormone which prepares us to fall asleep. So if a person is watching TV, working on the laptop or even mobiles, the touch kind of mobile or any kind of tab, before falling asleep, say before 2 hours of falling asleep or bedtime, then he reduces the chances to fall asleep. There are high chances that he will not be able to fall asleep. Similarly, a person who consumes any kind of stimulant late in the evening. For example, the usual bedtime is at 10, but he consumes coffee, tea, tobacco, cold drinks which contain nicotine or caffeine late in the night, late in the evening, say around 8 p.m. The person reduces the chances to fall asleep. Similarly, when we look at the sleep, we all know that the sleep is being governed by two different mechanisms. One is circadian factor. So the biological clock tells us this is the time to fall asleep, and you fall asleep. And on the along with this circadian system, we have homeostatic system. That means longer the duration we are awake, higher the sleep pressure, so the chances of falling asleep are high. But some people may fall asleep or they take a nap late in the evening. Suppose a person who wakes up at 5 in the morning and he takes a nap say 5 or 6 in the evening for 1 or 2 hours. Now this nap reduces the sleep pressure to a great extent and the person is having difficulty in falling asleep. Similarly, people who are consuming alcohol, especially before the bedtime, this also worsens the sleep quality. These people usually fall asleep easily, but the problem is by the time alcohol gets metabolized, say 3 hours or 4 hours, we all know it follows zero order followed by first order kinetics. So when the effect of the alcohol is goes, these people are not able to maintain their sleep and they often complain of early morning awakening. If you see the people who are having alcohol dependence, then if you take the history regarding this sleep, they would often say that look, I take the alcohol to fall asleep, but even with the alcohol I am not able to stay asleep. I wake up early in the morning. We must also look at the pre-sleep cognition. What does the person think before he goes to bed? If a person, some of the people they make the bed in the bedroom a battleground, especially cognitive battleground. So when they go to bed with lots of worries, lots of things to do, they plan the following day, they ruminate about their daily life problems, and all these problems and worries, they start the alarm system or alarm reaction in the body, so the person is not able to fall asleep. We must not forget to ask about the sleep environment, whether the place where the person is sleeping is comfortable, cozy. There might be too bright light in the bedroom or they must be working under a very bright light just before circadian system and the homeostatic system, but also by the social cues. So TV is a major social cue. If we are watching TV and something interesting is appearing on the TV, then we may not be able to fall asleep because that increases the alertness. Now, we should also ask about whether the person sleeps alone or with somebody else. We get a number of patients who say that they are not able to sleep properly because the bed partner is either snoring or bed partner is having some kind of parasomnia or they have any kind of movement problem in the bed. Then, as we mentioned earlier, we must ask about the daytime symptoms of the insomnia. And in the absence of daytime symptoms, we cannot diagnose insomnia. When a person with insomnia comes to us, we should not only talk about the insomnia, but we should try to inquire about other sleep disorders. For example, a person might be having restless behavior disorder. Many of these people, they act on their dreams, and this can be a problem, and this interferes with their sleep. Many of these patients, they complain that they are snoring. So the people who are snoring, they may have a problem what we call as obsessive sleep apnea or upper airway resistance syndrome, and this interferes with the sleep maintenance, and these people often complain of poor sleep quality rather than increasing sleep latency. Now, a number of times patients come that they have nocturnal leg cramps or restless leg syndrome or any kind of parasomnia. Most commonly is bruxism. Now all these problems, they also worsen the quality of sleep. So when we are dealing with a person with chronic insomnia, we should not forget to ask about other sleep disorders, and the best person to verify the presence of other sleep disorder is the bed partner. So sleep history should always be taken in presence of bed partner. Now this was a model which was floated by Spielman, and he mentioned that the chronic insomnia develops on the 3P model. 3P means there are some predisposing factors. That means some patients who are having chronic insomnia, they are biologically predisposed to develop hyperarousal, and which leads to insomnia. Now, when these predisposed people, they have any kind of precipitating factor which interferes with their sleep for a long time, insomnia starts, and then there can be some perpetuating factors which are most often behavioral. So we must ask about the predisposing, precipitating and perpetuating factors. For example, the predisposing factors are the female gender, family history of insomnia, because the stress reactivity, how do we relate to a stressful situation? It is being determined by the 5-HTP LPRJ, and this is the gene which also regulates the expression of depression and anxiety disorders. So we can say that hyperarousal is again being having a biological predisposition, and so it runs in the family. So we should ask about the family history. Then some of the people with insomnia, they may be able to identify the precipitating factors. For example, some might say that the insomnia was started when they were having some stress. It could be any kind of medical disorder or substance intoxication, substance withdrawal, or it could be associated with any kind of psychiatric disorder or any kind of medication, especially the stimulants. Or there could be any other precipitating factor, and sometimes patient may not be able to identify, but still we should try to find out the factors if we can, because when we plan the therapy for the chronic insomnia, it becomes very important that we try to avoid the precipitating factor. Now, there can be some perpetuating factor. For example, as we have mentioned, that some of the patients, they use the bed as a betting ground, especially cognitive betting ground. They keep on worrying about something, they try to solve all their daytime problems in the night, they try to plan whatever they have to do in their lives. So, these kind of things, they perpetuate insomnia. Medication overuse. Some of the people, as Bhattacharya was just mentioning, some of the people, they do high amount of benzodiazepines or other sleeping in the night, and when they have the afternoon effects in the morning, they abuse high amounts of stimulants. So this actually, you can say, just breaks all the circadian patterns which are important for the sleep, and these patients, they may prolong their insomnia. Some of the people, they have anticipated anxiety, and they are not able to fall asleep for 2 or 3 nights a week. Before bedtime, they start worrying whether I will be able to fall asleep or not, whether I will be able to get proper sleep. If I will not be able to get proper sleep, I will not be able to work properly tomorrow. Or they might be having dysfunctional beliefs. I must sleep at least 8 hours a night to function well. If I do not sleep for 8 hours, I might fall ill. I may develop hypertension or any kind of dysfunctional beliefs. So we have to address these kind of beliefs and anticipatory anxiety when we are dealing with the patient with chronic insomnia. Now, many of the people, especially shift workers, they have frequent changing sleep schedule. And when they have frequent changes in sleep schedule, their circadian clock gets disrupted. It doesn't know when to fall asleep, when to stay awake. Friends, what happens basically when we talk about the circadian system, there are 2 different procedures which run hand in hand. One is the propensity to fall asleep or sleepiness, and second is the alertness. Now, alertness and the sleepiness, both of them have different circadian patterns, but they are not mutually exclusive. So we must ask about these things. The people who are having frequent changes in sleep schedule, they have disrupted changes in circadian pattern of wakefulness or the alertness and the sleepiness. Now we must ask about the treatment, whether the person has any kind of treatment, what was the nature of treatment, was it kind of drugs or a kind of not planning the treatment on this episode. Poor quality sleep or suffer from insomnia, they are at higher risk. Now we have seen that number of sleep disorders, they can escalate insomnia and they should be ruled out. So we must look for the obesity, And the next circumference, we must go for complete neurological examination, complete physical examination to rule out any kind of cardiac or pulmonary problem. Because patients with congestive heart failure, patients with COPD, patients with ILD, they frequently have poor quality sleep. Then we must look for the nasopharyngeal examination and oropharyngeal examination, because this gives, all these examinations gives an idea about the probability of sleep apnea. Now, this was a paper which appeared a couple of months back in the journal Sleep, and these researchers, they took the people with insomnia, chronic insomnia, and they took the people with normal sleep and they followed them up longitudinally, and they found that around 50% of the chronic insomniacs, they met criteria for depression after 3 months. But again, friends, it is more important to understand that the insomnia is not just a symptom of depression or anxiety disorder. When you get a person who is suffering from depression and the insomnia, especially for more than 1 month, you must treat insomnia and depression separately. You must plan different kinds of treatment for both the disorders, because longitudinal studies which were conducted for more than 20 years by Taylor and Bussey, they have shown that after a long duration, say 6 months or 3 months, the duration can be variable from person to person. Primary disorder which started the insomnia, whether it's a medical disorder or psychiatric disorder, it gets dissociated from insomnia. Now, even after remission of the psychiatric disorder, and since we are in the psychiatric branch, even after remission of the depression, number of people, they still have the insomnia. And if you remember, we had a concept of residual symptoms of depression, and insomnia was one of the major symptoms, residual symptom of depression after complete remission of depression, if you look at the literature till 2012. So, our current understanding with the DSM-5 and the ICD-3, and probably the ICD-11 is also be following the same kind of guidelines. So it says that chronic insomnia is a comorbid condition along with a psychiatric disorder. So treat them separately, plan the treatment separately. Again, as we have mentioned, that these people are at higher risk to develop depression and anxiety. So we must go for a proper mental state examination, and the list is actually endless. It is almost impossible to cover how to evaluate a case of chronic insomnia in just 30 minutes. Each case is having its own things, and once you start seeing the cases, you start working on it, once you start reading the literature, you will be having a better idea what to ask and what you can leave in a given case. Now, sometimes the patients, they come to us with poor sleep quality, and when we ask the bed partner, does he have the same kind of problem that he says? Or patient might not be having the daytime symptoms in proportion to the amount of problem that he is having at the night time. In those cases, we must suspect the sleep state misperception. So we need to have some objective data. So the simplest data is the sleep log. Now this sleep log, as you can see here, it has a box for each hour from morning to the next morning. So it's a 24-hour boxes, and the person mentions the time to bed and the time he has spent in sleep and when he woke up. Now here you can see that the person went to bed around 7 in the evening and he fell asleep within 30 minutes and woke up at around 3:30 in the morning, but he was not able to leave the bed till 6 in the morning. And he was trying to fall asleep deliberately because he thought that I am not able to catch the proper sleep. So these kind of people, they are suffering from advanced sleep phase syndrome. If you look at the sleep duration, it is around 6.5 hours. And you can see for almost 7 days, he is able to sleep for around 6 to 7 hours. But the problem is, he wakes up early and goes to bed early. So this is what we call as advanced sleep phase disorder. Similarly, here you can see the lower sleep log The person goes to bed at around 3:30 in the night or 1:30 in the night or after 12 in the night, and he wakes up at around 3 in the afternoon. Now if you look at the duration of the sleep, it is okay, but only timing is a problem. And many of these patients, they come to us with complaints of insomnia, and they are sometimes misdiagnosed as a case of initial insomnia. But actually what they suffer from is delayed sleep wake phase syndrome. So these patients should not be given any kind of sleeping pills. Rather, we should try to improve their circadian system through chronotherapy. Now, this sleep problem again having one problem because the person himself fills up all the data. So it may, you may not get the adequate data in cases of sleep state misperception. For those cases, we have an actigraphy. Actigraphy is a small watch-like instrument which measures the movement, and it works on the principle, on the assumption that the person makes little movement during sleep. But if a person is suffering from any kind of sleep-related movement disorder, then we should not use this kind of technique to measure the nighttime sleep. Now, this actigraph is to be worn on the non-dominant hand during almost 15 days, and it records the activity. So these black lines, they show the periods of high activity, and these blue part, it shows the periods of relative inactivity. So this is the time when the person was sleeping. Here you can see the person was sleeping almost for 6 to 7 hours a day or almost all days. So these patients should not be given any kind of sleeping pill. Now, even with, say sometimes we are not able to get adequate data which goes along with the clinical picture. And in those cases, we need to go, or sometimes we suspect the central sleep apnea or obstructive sleep apnea or any other kind of sleep disorder. In those cases, we have to make the patient undergo the polysomnography. But friends, remember, polysomnography should be done with level 1 machine, which will also record the EEG data, and it should be scored manually. Number of companies with PSC machine now say that they are having polysomnographs which automatically scores the whole of the sleep, the data of the whole night, but this data is not reliable even with the best Western machines. So you should first learn how to score this sleep data. You should do it yourself. Then there are some questionnaires which we can use to measure the sleep quality of these patients, and these questionnaires help us in planning the treatment longitudinally. One of the scale is PSQ, or Pittsburgh Sleep Quality Index, which asks you about the sleep quality in past 1 month. It is available in Hindi. It is free of charge. Then another scale is the Insomnia Severity Index, which is having 7 items which are being rated on 4-point Likert scale. We have translated this scale into Hindi, and it is available on request. Then another scale is Dysfunctional Belief and Attitude About Sleep. 16 items, a brief version, original scale of 30 versions. We have translated this scale into Hindi, and it is also available for free. Then there is the scale first, which measures the hyperarousal or the chances of having poor quality sleep under stressful situations. And we may use the expert sleepiness scale, which is an 8-item scale which measures the chances to fall asleep or daytime sleepiness on 4-point Likert scale, and a score of more than 10 says that the person is having high chances of excessive daytime sleepiness. Now, once we take the history, once we take all the investigation, now the question is how to treat the insomnia. Now, when a patients with insomnia, they come to us, many of them have some unrealistic expectations. And we have to ask them, look, I cannot do any kind of miracle. We are working on the insomnia, it's a chronic problem. Behavioral therapy is the mainstay of treatment. Onus is upon you, I can only guide. And it is your responsibility to provide me the right data at the right time. So when we looked at the treatment of chronic insomnia, as we have seen that these patients, they often have comorbid problems. So we must treat the insomnia and the comorbidity, both the things differently, separately. and we can plan pharmacological and non-pharmacological treatment for each of these problems. Now coming to the pharmacological problem of insomnia, for a short term we can use either the sleeping pills or the chronobiotics. Now sleeping pills are different from the chronobiotics. Chronobiotics are those drugs which act on the melatonin receptors. Now it can be melatonin itself. Different classes of drugs. We can choose from antipsychotics, antidepressants, antihistaminics, benzodiazepines, or Z drugs. Each of these drugs, you all know, they have their own strength and their disadvantages. Now, the mainstay of treatment for the chronic insomnia is cognitive behavior therapy for insomnia. The basic framework is a person might be having stressful thoughts, which induces the stress or anxiety or the worry. Now this stress or anxiety transforms into the physical tension, and with physical tension increases the alertness. So person may adopt inappropriate sleep habits or sleep-related behaviors. For example, a stressed person may be consuming tea in the night, coffee in the night, which further worsens the sleep. Once they are not able to fall asleep properly, or once they are not able to get adequate sleep, they feel stressed, and so the vicious circle goes on. So when we look at this cycle, we will break it 3 different levels. One is at the thought level. So we have to plan the cognitive restructuring. For physical tension, we plan the relaxation techniques, and then we have to change the sleep-related behavior or pre-sleep behavior or pre-bedtime behavior and the behavior during the awakening. Now, we have to explain the patient then that the sleep depends on what you think, how you feel and what you do. So these 3 things are actually interviewed. And when we look at the different components of cognitive behavior therapy for insomnia, it is the education regarding the sleep. We must educate the patient regarding circadian system, regarding the homeostatic system, the sleep hygiene, the relaxation therapy, sleep restriction therapy, stimulus control therapy, and cognitive restructuring. Now, taking each of these components one by one, when we are dealing with a patient with chronic insomnia, we must educate the patient regarding the circadian system. What can happen if he is not following or he is not respecting the circadian system rule? What can happen if he is left late in the night, so he uses the homeostatic drive? And we must explain the effect of the social and environmental cues. If a person is in a party, he may not fall asleep till 1 in the night, but if he is not in the party or is probably reading or in the bed and not watching TV, he might feel sleepy at around 10 in the night. So we must explain the effect of social and environmental cues on the propensity to fall asleep. Then we must explain about the sleep hygiene. Sleep hygiene says that there should be a fixed bedtime and wake time. We should try to reduce the caffeine intake in the morning, especially in the night. We should not watch TV, we should not watch on the work on the laptop or any kind of bright screen before the bedtime. When we go to bed, we should not be either too hungry or too full of a stomach. We should engage in regular exercise, but at least 4 hours before the desired bedtime, because exercise also increases the wakefulness or alertness. We should take the beverage from the consumption before the bedtime, especially the alcohol. We should try to have a proper cozy environment for the bedroom. And the bed in the other environment should be comfortable enough to fall asleep. And we must try to use our internal biological clock to fall asleep and to awake. We should try to reduce the use of alarm clock. Now, many of these patients, they keep on worrying about their insomnia before they go to bed, and it increases the alertness. So we have to go for a cognitive restructuring. DBAS is DBAS 16, or the dysfunctional behavior and attitude about sleep. It's a very good scale to find out the dysfunctional beliefs in these patients, and we can use the items on the scale for cognitive restructuring. Of course, the the pre-bed thoughts or cognition, it varies from person to person, and we have to work besides these 16 items. We should try to find out what kind of thoughts that he has. Then stimulus control therapy works on the behavioral learning. Stimulus control therapy says that when a person is not able to fall asleep or maintain the sleep in the bed for a very long time, he gets negative association with the bed and the bedroom. In the bedroom. So the person is, we say the person within 15 minutes, he should leave the bed, he should go onto a chair, and he should try reading something boring. He should not use the bed for anything else except his sleep. Now this stimulus control therapy, among all kind of different therapies of which have been included in the CBTI, is most appreciated and has been found to be most efficacious. Now there can be patients who might be overspending time in the bed as compared to their sleep time. For example, if you see here in this sleep log, sir, just 2 minutes. So this person is spending around 2 to 3 hours staying awake in the bed. So this actually increases the frustration in the mind of the patient, and chances of falling asleep decreases and perpetuates insomnia. So in such cases, we reduce the time in the bed. So the take-home message is chronic insomnia is a common problem. The cost of untreated insomnia is high. Untreated insomnia may lead to medical disorders. Adequate diagnosis is important. All the patients who complain of chronic insomnia might not be suffering from insomnia. We should look at the other sleep disorders, and mainstay of the therapy for CBTI, for chronic insomnia is CBTI. Thank you. I hope I was able to make you fall asleep.
I am sure that he will be glad to reply.
Coming to bruxism, how do you go about it?
So some people are short sleeper, for example, they feel fresh after 4 hours or 5 hours of sleep. And on the other hand, there are some people who are long sleepers who need at least 10 hours of sleep every day. But in general, if we see we should not ask about, tell the patient to stay asleep for 8 hours or 6 hours, because that also increases the anxiety in the patient if he is a short sleeper or long sleeper. So we should rather ask what was the usual sleep time or total sleep time when you have the biological need of the total sleep time. Coming to your second question, bruxism is a difficult situation, and as of now, despite so much of research, we still do not have any understanding regarding the pathophysiology of bruxism. But it has been seen that the patient, now again when we look at the bruxism, we can classify it into 2 different types. One is the nocturnal bruxism and second is the diurnal bruxism. So people who remain stressed, they keep their teeth clenched during the day. Instead of hyperarousal or predisposed hyperarousal, it can increase that. From the insomnia point of view, more important is the nocturnal bruxism, where the person grinds the teeth in the night, and still we do not have any exact understanding regarding the pathophysiology. So as of now, we treat the bruxism just in a symptomatic manner. So most of these patients, they damage the enamel of their teeth. We ask them to use a teeth guard, which is a silicone pad, which also reduces the load on the muscles, and so it reduces the damage to the TMJ and also reduces the morning headache. Besides,
a student from Department of Community Medicine. So we are usually posted in rural areas. So we also get patients that have insomnia, like they complain that they are decreased sleep. So like I want to ask in relation to like drugs, like which drugs are good, like benzodiazepine or nitrazolpidem. Or secondly, people also say that we want Alprax. So like some people also say that Alprax is not to be used because they have become of substance abuse. Then if it's substance abuse, then why is it available in the market?
Who are staying in the rural area, they usually go to bed at around 7 in the night, because fortunately they don't have the electricity. It's very fortunate for them. And they usually wake up at around 5 or 6 in the morning once the sun starts coming. So But if you look at the total bedtime, it is more than around 9 or 10 hours. And we all know that most of us, we are not able to fall asleep for more than 6 or 7 hours. But if you look like we have, and they have multiple auditory meetings and it is similar to the sleep pattern that we see animals. So you must first try to find out whether they are actually having insomnia, and to measure the insomnia, the best thing is to find out the daytime symptoms. You ask whether he is having any daytime symptoms. If the person is not, then you may use different kinds of drugs you have mentioned. Whether the benzodiazepines, they have an addiction potential, or the drugs, they have an addiction potential, it's a controversial issue. I did not find it. I think if you look at the literature, most of these people, they are anxiety disorder, insomnia, they are a chronic course. And once the people, the patients, they try to get them withdrawal syndrome. Person must have an urge to take the drug, the craving should be there. There should be an increment in the amount, and there should be given amount. They are not engaged constantly into seeking a drug. They do not have any kind of withdrawal symptoms except insomnia. So I think it is better to not to use drugs if it's a chronic insomnia. Try to use the non-pharmacological means.
Use insomnia among the youngsters who are almost dependent on Facebook and mobile and WhatsApp and all. They don't want treatment for that. But they refuse any tablet for sleeping. How do we deal with these people? We do counsel them, but good number of them, either in the name of studying late in the night, or do not feel that they are insomnia.
Sir, these patients are actually on their sleep pattern, that is all.
Hello, sir. I have a small question. On a lighter note, sir, we all have seen the movie 3 Idiots. So in that, Baman Irani used to take a 10 minutes power nap listening to the opera. So I want to know if there is any reference to it in the literature, and if there is, can it be of any help in treating this?
Particular, it can actually improve the functioning.
So basically I want to ask if there is any difference between the daytime
sleep. The people with the circadian sleep disorder, for example, delayed sleep syndrome, they usually sleep late in the night and they wake up late in the morning. And when we look at we all know that the sleep is consisted of the non-REM sleep and REM sleep, and the propensity to REM sleep is governed by the circadian rhythm. So REM sleep increases during the morning hours and in the initial first half of the day. So these people, they have high amount of REM sleep and very small amount of slow wave sleep. So even when they wake up, they do not feel fresh.
And may I request our chairperson, Dr. Burmani sir, to kindly present a memento to our speaker as a mark of love and appreciation. May I request Dr. Mrs. Shashi Rai to present a memento to our chairperson as a mark. Thank you, ma'am. Thank you, sir. Devi. I welcome the chairpersons, two eminent psychiatrists, Dr. Vineet Gupta and Dr. Amarjeet Popi. Welcome, sir.
Good morning to all. I feel honored to chair this session, as I admire Dr. M.S. Bhatia as a lot, as a lively person, as a favorite teacher, senior colleague, friend, and whatnot. Though you all know Dr. M.S. Bhatia very well, he does not need any introduction, but still as a custom I have to introduce him. Dr. M.S. Bhatia is Professor and Head Department of Psychiatry, University College of Medical Sciences, Dilshad Garden, New Delhi.
there are a lot of publications and textbooks to his name, and PG students must be knowing him very well, as he has authored many books on the preparation of PG entrance examination, and he has also authored many well-known textbooks in the field of psychiatry. And seeing the shortage of the time, not going into the detail, I invite Dr. M.S. Bhatia to deliver his thoughts.
So I think this session is continuity with what Dr. Ravi has presented, and in our traditional principle that you should have a healthy diet, good exercise and a good sleep. And you can, I think, prevent majority of psychiatric disorders. So I think in the future, the most stress is going to come on the first level of prevention or primary prevention. There is a health promotion and specific protection. So these things are coming into the health promotion and specific protection. But majority of stress, we can say 99% is on early diagnosis and treatment. But ultimately, we have to divert our attention towards promoting health and specific protection of a person from different kinds of psychiatric disorders. So this topic has again been one of the neglected fields in majority of psychiatric textbooks. I would like to cover what is evidence-based and what we should know. So healthy diet, everybody knows healthy diet related to healthy body, and healthy body related to the healthy mind. So now field of nutrition coming up, there are specific diets, specific vitamins, specific food supplements which have been devised to in the treatment of psychiatric disorders. So nutrition, you should know that it's defined as a science of food and its relationship to the health. Nutrition neuroscience is again the emerging field that deals with the nutritional factors and the correlation with the human cognition, behavior and emotion. What of a balanced diet? A balanced diet provides nutrients in adequate amounts and proper proportions. There are many nutrients which are stored in the body, but there are many nutrients which have to be taken daily, but they cannot be stored in the body to save a person from developing any kind of physical or mental disorder. So balanced diet can ensure a balanced mood and a sense of well-being, which can be achieved through adequate amounts of carbohydrates, essential fats, amino acids, vitamins, minerals and water. A good and balanced diet is essential for mental health, and various mental diseases are influenced by our dietary lifestyle. So balanced diet, everybody knows. The nutritional factors are closely correlated with our human cognition, behavior and emotion, and food plays an important contributing role to the development, management and prevention of specific mental health problems such as depression, schizophrenia, attention deficit, hyperactivity disorder and Alzheimer's disease. There are many incidences in psychiatry in female patient suffering from anemia, iron deficiency anemia or reguloblastic anemia, presenting with the typical features of anxiety disorder. Persons keep on treating in the anxiety disorder, person does not improve unless and until you treat the anemia. So there are many dietary factors which are linked to psychiatric disorder. This is about depression also. The person is deficient in specific nutrients, you keep on giving any drugs. What the person is going is not going to improve, or they may become dependent on those drugs. So malnutrition is a major problem in developing countries. Everybody knows malnutrition in early infancy results in the number of neurons resulting in intellectual disability and mental retardation. So we are putting our children, we have a younger children, about 45% of our population below 15 years of age, and younger population, if they are deficient in nutrients, they have a long-term impact on their cognition. Apathy is the most constant and earliest neurological feature and present in children with the protein energy malnutrition. The The psychological manifestations they include cognitive inadequacies, result in delay in learning, particularly reading and writing. So many of these specific learning disorders, they are also being attributed to the specific deficiencies in nutrition. Eat regular meals throughout the day to maintain blood sugar levels. Make sure you eat at 3 meals each day. Missing meals, especially breakfast, lead to low blood sugar, and this causes low mood, irritability and fatigue. So many of the people who go for the examination, they don't take the sufficient breakfast, or they don't take the CNS stimulants which they are regularly taking. They keep on taking caffeine in adequate amount daily, but on the examination day they misses it. They have a poor performance in the examination. And with the timing also. Now the typical PG entrance examination, other examinations, they have a different slots. Persons who are in the morning, who are appearing in the morning, they have a better alertness as compared to people who are appearing in the afternoon. So it's advisable to take a morning slot when you are appearing in the examination. You have an option to appear in the examination. If you are feeling hungry, you have to take a healthy snack. The changing in the dietary patterns, the changing lifestyle, access to more of processed and manufactured food, in deteriorating the quality of food and hence the health. So changing food habits, especially in school children. Now the government is putting a pressure to ban all these products in the schools, but they are putting the children at the risk of developing blood pressure, high salt content. They are putting the children to have obesity, taking high sugar, again putting the children to developing diabetes. Fusion of brain and neurons, 20% of the fat, because they are not of the same quality as a person who is taking the normal diet. The amino acid tryptophan, tyrosine, phenylalanine and methionine are often helpful in treating many mood disorders including depression. And tryptophan is a precursor of serotonin, and serotonin is deficient in depressed patients. Tryptophan is also high in some of the dietary products, and they are also being linked to providing solution, partial solution to insomnia also. Like diet which is rich in the lactate, they are helpful. Then talking about the role of food constituents and mental health, deficiency of omega-3 fatty acids are related to high incidence of depression. In depressed patients, daily consumption of dietary supplements of omega-3 fatty acids that contain 1.5 to 2 gram of omega-3 fatty acid has been shown to stimulate mood elevation, but it's not a solution for depression. And this is a study which has been done on the hyperactive rat. The rich diet in omega-3 fatty acid significantly reduces the impulsivity in hyperactive rat. Diabetes mellitus results in hyperglycemia with depression and anxiety symptoms in the patient. Hypoglycemia can also manifest with psychiatric symptoms like apathy, fatigue, confusion, hallucination, mood lability, stupor, and ultimately person may end up in coma. This is especially true about the children who are going to school without a breakfast, without a good breakfast. They have problems in learning. So one has to be very careful. And talking about the SANI, this is a substance which is being marketed by many pharma companies in the treatment of many psychiatric disorders, but it has been a predominant role in the liver disease. Especially persons have a moderate to severe alcoholic liver disease, this particular molecule have a role. The other indications which have been given to this particular molecule is diabetes, Cushing disease, pancreatitis, inflammatory bowel disease, certain anemia, autoimmune disorders and certain heart conditions, and not for the depression and other conditions for which this particular molecule is routinely being marketed without any approved indication. And besides folate and depression, there is a definite role. A recent article by Stephen Straub has provided this trimonoamine modulator to boost the synthesis of 3 monoamines, dopamine, norepinephrine and 5-HT. It's given as an augmenting agent. This is an augmenting agent. This is not the first line treatment for the depressed patient who are unresponsive to traditional antidepressants. It is marketed in USA as medical food, not routinely being given to the patient. Then antioxidants and anxiety disorders. This is an Indian study published in Indian Journal of Psychiatry by Gautam et al. They reported that GAD and depression, they had significantly lower levels of vitamins A, C and E in comparison to healthy control. And after dietary supplement of these vitamins for a period of 6 weeks, a significant reduction in anxiety and depressive score of patient was observed. Then talking about autism and the dietary sector, there has been a series of articles about autism. Some patients of autism, there are different theories of autism. Some patients of autism which have been shown to have excess levels of IgG or IgE antibodies in response to allergens to food. They are allergic to food, especially the casein or milk protein or medicine or environmental inherent. There is also role of probiotics. A diet that eliminates gluten and casein is often the starting point of journey to dietary intervention in autism. Then there are also the body ecology diets which have been marketed, pioneered by Donna Gates, focuses on the rebuilding immunity and intestinal flora. This diet uses the traditional healing principles such as the use of fermenting food. So there are controversial roles, especially there are selective groups in which these particular interventions they improve. This is not the treatment of all autistic children. The role of vitamins in mental health. All vitamins and minerals are involved in one or more biochemical pathways or physiological actions which influence the function of human brain. In biochemistry, this is typical first lesson learning that every neurotransmitter can be changed into another neurotransmitter by the brain. This is the beauty of the brain. It can change one neurotransmitter into another. It is a biochemical pathway, and there has been many you can say senses that this particular molecule, especially schizophrenia, acting on a 5-HT, acting on the serotonin, is actually helping the schizophrenic patient with a lower side effect. This is not the same. Brain has a beautiful capacity of changing one neurotransmitter to another. Changing the neurotransmitter. So one has to be very careful. Who is entering the house, it has 5 gates. One can enter from the front gate, one can enter from the behind gate or the side gate. The same theory is about schizophrenia. So all the neurotransmitters, you are ultimately going to enter the drawing room or the house. So all the neurotransmitters, they have the essential tendency to change one neurotransmitter into another. If you are taking the essential dietary supplement or food diet, so brain has the capacity. B1 deficiency, deprived patient, again is becoming more common, less detected by the psychiatrist, more detected when the person comes with a typical history of alcohol intake or any kind of particular physical disorder. So one has to be very careful. The person can present with irritability, agitation and emotional stability, and it's a fully treatable disorder. So different psychiatric syndromes like vertigo and encephalopathy, Korsakoff syndrome, they are essentially treatable disorders in early stages, and including the dementia. Riboflavin, again, deficient patients will show increased levels of depression, hypomania and psychopathic behavior. Pyridoxine, again depression. And in infancy, deficiency may lead to seizures and mental retardation. B12, deficient in persons, especially who are vegetarians, one has to be careful. When taking the history, you take the dietary history. This is very important when you are treating a particular psychiatric disorder, not only sleep disorders, but any kind of psychiatric disorder, please take the dietary history. The dietary history is not a part of psychiatric history, but one has to take the dietary history. And as Dr. Shashi was saying, if you treat the mentor, female is a mentor of a house, you ask the mentor to what is the essential nutrient, what is the balanced diet, she can take care of many of the psychiatric disorders in the family. So depression is also a common early psychiatric manifestation of B1 deficiency. Person may have mental slowing, confusion and memory deficit. Peripheral neuropathy or encephalopathy are also the symptoms. Vitamin C, fatigue, weakness, reported to be the early symptoms of scurvy. Depression is a classical early symptom. vitamin D, we have done a study in our hospital among the psychiatric patients who are attending the psychiatry OPD, more than 90%. And among them, there were few doctors, and all 100% doctors, they were found to be vitamin D deficient. So there is an epidemic in India where there is less exposure to the sunlight, persons are found to be vitamin D deficient. It's a major problem, and depression is typically linked to vitamin D. And there are other studies which are coming with the schizophrenia, anxiety disorder, other psychiatric disorders related to vitamin D deficiency. So one has to be very careful. Recently we come across a surgeon who came to psychiatry OPD, working in our hospital, a senior professor, with typical features of depression. So I requested him to get the vitamin D levels. They are found to be highly deficient, 3 levels. Normal levels are 45, you are 3, having a 3 level, 3 nanogram per ml. So you are advised to take vitamin D supplement without giving any psychiatric treatment. He improved within 2 months. No psychiatric intervention was given. He is working now from 9 to 4. You are taking leave frequently, but he is now working on. So it's like, especially people who are typical features of apathy, lethargy, not feeling to or having cognitive slowing, not kindly gets your vitamin D level because you have less exposure. When you go out, the sunlight is not there, or you have sufficient creams for the face which prevent the absorption of sunlight. So vitamin D deficiency is going to be an epidemic, especially in patients who are having typical features of depression or other psychiatric disorders. We have in a recent study which is still going on known as somatoform disorder. Patient deficiency in vitamin D is typically related with the multiple somatic features. And to treat the vitamin D deficiency, they improve without any psychiatric intervention. There is an ongoing study with the vitamin D supplement and opicromol. You will find the patients who are giving vitamin D supplement, they significantly improve more than the persons who are giving opicromol. Then folate deficiency, again patients with depression and sexual dysfunction. There is recent study coming out with the maternal use of folic acid supplement in early pregnancy was associated with a reduced risk of severe language delay in children at the age of 3 years. This is a double-blind study which has been conducted in the giving food supplement in one group, and in the other group there was no food supplement given. The persons who were given folic acid supplement, they had a better outcome in the children. Then niacin deficiency, everybody knows the pellagra, it leads to dementia, maybe the delirium also, and the specific symptoms like increased psychomotor activity or psychomotor drive, fatigability, headache, sleep disturbances, mixed anxiety and depressive features. Then side effects are also related to excess nutrient intake, especially people who cannot metabolize, like children who cannot metabolize phenylalanine A, especially who are giving the vitamin A supplements. Kept on taking the vitamin D3 supplement 60,000 units. He had to support to take 60,000 units once in a week. He mistakenly being taking this every day. So we don't know the toxicity of vitamin D. So one has to be very careful when you are giving vitamin A or vitamin D. Then magnesium deficiency also being linked to depression, behavior and personality changes, apathy, irritability and anxiety. There has been less attention which being given to the magnesium deficiency. Individuals with low CSF levels of magnesium tend to have low levels of 5-HIAA, a metabolite of serotonin, which is again an essential requirement for having a normal mood. There is a study which has been conducted in the persons with the major depression. Zinc, again, everybody knows, are significantly lower in depressed patient as compared to healthy price control. Person is deficient, one has to supplement it. And many children with ADHD have lower than average zinc level. And if they are having lower levels, one has to give the zinc supplement. And in India, many of the vitamin B supplement, they have been essentially being supplemented with zinc. Calcium, again vitamin D deficiency, again leading to calcium deficiency. So research has shown that use of SSRI inhibit the absorption of calcium into the bone, putting them at risk of fracture. This is true about methylphenidate also when we are using the drugs for ADHD. So these drugs are interfering with the calcium metabolism. Iodine again is essential in the formation of thyroid hormone, which plays an important role in the maintaining the BMR. And hypothyroidism, everybody knows, again present with the typical features of depression. Iron deficiency, apathy, fatigue, kindly tell, especially in the ladies, kindly get the normal levels done, especially person in iron deficient can done the whole iron profile and give the anti-hypertensive drugs if required to treat the anemia. Treat the anemia fully, unless until you treat the anemia, person will keep on having the symptoms of anxiety and depression, they are not going to improve. Again, putting a lot of stress on the electrolyte imbalance, which is related to sodium and potassium, irritability, lethargy, neuromuscular hyperexcitability, paresthesia, apathy, seizures, confusion, stupor and coma. Visual hallucinations are common in persons with delirium due to electrolyte disturbance. There is an epidemic in Delhi. We are finding lot of elderly patients coming with the delirium or patients typically of depression who are having hyponatremia. Role may be attributed to the high class filters which remove the sodium. So they are being advised to take the normal tap water also along with the filtered water. So the person having a hyponatremia, especially elderly, coming with the typical features of delirium, kindly get the sodium levels and potassium levels done. If they are deficient, they are advised to take sodium levels. This is true about the person who are restricting the sodium levels, especially they are hypertensive. They are taking diuretics, they have been advised heart restriction. So they are putting more at the risk of developing delirium and depression. Then talking about the role of diet in specific mental health problems in patients, complex carbohydrates and certain foods such as folic acid, omega-3 fatty acids, selenium, tryptophan thought to decrease the symptom of depression. And depression is again linked to low level of serotonin, which precursor tryptophan is purely derived from the food. Intake of carbohydrate triggers insulin release and insulin lead to taking of glucose into the cell, simultaneously triggering entry into the tryptophan into the brain. So tryptophan again you know that regulates the mood. So food and mood they are interlinked. Schizophrenia persons, people who have schizophrenia, they have low levels of unsaturated fatty acid in their body. Another research shows the deficiency of antioxidant enzymes implicated in the etiology of schizophrenia. This is one of the theories. Alzheimer's disease, lot of research has been done on the antioxidants. High intakes of vitamin C and E linked to the lower risk of Alzheimer's disease, particularly ADHD, essential fatty acid, found to be significantly low in hyperactive children, and significant relationship also been found to with drugs. Lithium therapy can cause the blood glucose level leading to diabetes mellitus. So, second generation drugs, one has to be very careful. These are some of the references you should know. You want to study the role of dietary factors. So the dictum goes, person should take healthy diet, person should take good exercise and good sleep. You can prevent majority of psychiatric disorders. So when you are practicing psychiatry, so you have to put lot of stress on the prevention of psychiatric disorders. Asking me in one of the presentation, is there any role of fast in today's life? I say this is a traditional principle and this is more valid in today's life. Because when you are taking too many toxins, be very careful with person having any comorbid physical disorder. One has to advise accordingly. Thank you.
Now I invite audience for any queries and comments.
Capacity of changing the neurotransmitters. So can you tell me, give me 1-2 examples, because I am in pharmacology, I was curious about this.
So all neurotransmitters are interlinked. So as many as neurotransmitters you know, they are all linked to serotonin. There are various hypotheses, but the hypothesis is who are working in the pharma industry, they are working on the drugs which are acting on 5-HT. They put a more stress on the 5-HT hypothesis. So ultimate hypothesis is the dopamine deficiency. So all HT one is deficient in dopamine, is working 5-HT, again going to change into the other neurotransmitters. So the brain has a beautiful quality. You are providing the good food to the body. It has a beautiful quality. Body has a beautiful quality. Even liver has a beautiful quality to control many of the deficiencies if you are having good diet.
I have a question. We definitely affected this area, and many of us do not offer supplements to our patients. They are even you are carrying out a study on vitamin D deficiency. I have a doubt. So many companies have brought out vitamin D tablets. I do not understand how a fat-soluble vitamin can be converted into a tablet. I have asked a few companies to tell me how it is done. There might be a technology I am not aware. And what type of vitamin D in case you are providing. So my knowledge, common sense says it has to be an injection. Because even the calcium and all that given in milk, I have done this investigation thoroughly, given them these calcium, but it never really raised the vitamin D levels substantially. Whereas injection vitamin is only one company making it, and I do not know why any other company is not manufacturing injections.
I strongly agree with you.
We are making them buy something useless. All other fat-soluble vitamins are available either in the
you can say oils, cooking oil, which have been
could have been made into powder,
which have been claimed to be supplemented with vitamin A and D. I have a strong doubt. And then you can reduce it to monthly 1 lakh units per month. And according to the endocrinologist in our hospital, he says you need not get the vitamin D levels done in every patient. You take the patient as a vitamin D deficient unless and until proved otherwise. So vitamin D levels are actually more costlier than treating the vitamin D deficiency.
It is not in the form of peptides, that is not true. All which contain
global tablets.
And secondly, one major issue is when I was discussing this issue with one of the orthopedists, he mentioned that he do not feel the data regarding the normal vitamin D levels for the Indian.
Laboratory was to get it done. And one testing is costing around 1,500 rupees to 2,000 rupees. You treat the vitamin D deficiency, cost around 400 to 300 rupees. So what the food supplements which are claimed to be having enrichment, I have found out because the quality control has not been done for a long time, even for the Ayurvedic side. They are putting our children at risk. Even with the oils also, which are claimed to be vitamin D supplements, they are not actually correct.
I remember
what the cardiologist
lactating mothers and neonates, more than 90% were severely deficient in vitamin D. I do not know what could be whether there has been any follow-up study on that. Any study which are available. Same patients.
And other journals like IAPP, Journal of Association of Physicians of India, they have found out that the vitamin D levels in females, they are low in in a pregnant female is low is putting the risk to the fetus also. Because now the vitamin D, there are hormones believed to be acting centrally also. They have a central receptors. That's why it's influencing the mood also.
I have a question.
From psychiatric point of view, on with physical disorder like seizure disorder, or you are giving any anti-epileptic drug, kindly get the vitamin B12 and folic acid and iron levels. And then Dr. Krishna has said vitamin B levels also. Then if they are deficient, you have to feed them.
So what can Alzheimer's children?
They are beneficial. They are rich in antioxidants. But person in taking excess quantity, they are not very so useful. Well, one has to limit the quantity also.
Thank you all and Dr. Bhatia for a wonderful discussion. I am surprised to see the dimension and breakthrough can come from this type of molecules, Bhatia, and close this session.
Good morning, friends. Management. Tobacco was introduced to India by Portuguese about 400 years back. But tobacco addiction problem has increased in our country, as is very clear from the facts that there were about 182 million people by the study of Gajalakshmi C. et al. 2000. But if we go by the recent figures, then there are about 275 million Indians, 35% adult population, and 14% children aged 13 to 15 years are tobacco users, mainly smokeless tobacco. So this is the gravity of illness. Recent report by Public Health Foundation of India estimated the cost of the disease caused from tobacco use, especially respiratory disease, tuberculosis, cancer. It estimated the cost attributable to tobacco use in 2011 at over 1 lakh crore, 12% more than the combined state and central government expenditure on healthcare in the same year. This is the gravity of this illness. Though the tobacco addiction has come down due to the efforts by our medical fraternity, then supported by government programs, but still the problem is day by day increasing. Some of the efforts by the government has been like hike in the excise duty on cigarettes from 11% to 72%. And the government has also raised taxes on pan masala, gutka and other tobacco products. Our central government has been sending directives to the state governments to increase the VAT on tobacco and its products. But still, the problem is quite alarming. To discuss tobacco addiction prevalence and management, we can't have better person among us except Professor Director R. Sujulova. He is my past teacher. He is heading the Department of Psychiatry in Jimhan Hospital. He has done a lot of work on drug addiction, published many papers, authored many books. He has been advising to the Government of India, especially Government of Delhi, regarding mental issues, and attended many national and international conferences on this subject. So I will not take much of time and hand over the mic to Professor R. Sujulova, who will enlighten us regarding tobacco addiction prevalence and management. Please, Professor R. Sujulova.
Very well.
tobacco is quite rampant in our society. Tobacco use is surely one of the strangest of human behaviors. How is it that nearly 1/3 of world's adult population performs this strange act, which is necessary neither for the maintenance of life, nor for the satisfaction of social, cultural or spiritual needs, an act which is acknowledged even by the smokers to be harmful to health and even distasteful. The ubiquity of tobacco use and its persistence in the face of vigorous proscriptions and in our own times, despite the generally agreed health risk, is a remarkable phenomenon. Within a span of few decades after Christopher Columbus, a Spanish navigator, and his team observed for the first time in 1492 the natives of America smoking the leaves of plant which was later identified as tobacco, the use spread all over the world and assumed a great social, economic, political, industrial and medical importance. But right from the time of its introduction from America to the rest of the world, opinions about tobacco radically differed. In part, the earlier reports praised it to be a herbal panacea for all human suffering, while other reports said that it's an invention of a devil because it was used in the magical religious rituals of the natives of America. However, these 500 years of tobacco's availability in the world have given ample opportunity to the commercial forces to engineer addiction among its users and spread it all over the world. Today we know adequately enough that tobacco not only causes addiction, it harms each and every organ of the body. It causes many diseases. It compromises the health of the user. It shortens lifespan and causes premature death. Tobacco is a plant product. And the plant from where tobacco is obtained comes from the Solanaceae family of plant families. Unlike other members of this family, like potato and tomato, which have uncontroversial nutritional roles, tobacco plant carries in its leaves the quantities of an alkali which gives power over man's mind. The main source of tobacco is from the family Nicotiana tabacum. While in some parts of the world, like in about 100 countries across the world grow tobacco for personal use, for personal consumption, as well as for commercial purposes for export. The 10 most leading. So how is tobacco used? See, after harvesting tobacco plant and curing tobacco, the leaves are manufactured into two varieties. One is smokeless tobacco and other is used for smoking purposes. The smokeless tobacco is used while the smoking products are in the form of cigarette, more commonly used because of the economic reasons. From the incandescent tip of the lighted cigarette burning at a temperature of 800 degrees Celsius, tobacco smoker with each puff
carries into his mouth and lungs a broad portfolio of gases and many side parts. And about 7,000 chemicals have been isolated from tobacco smoke. In tobacco leaf, they have isolated around 4,000 chemicals. And out of these 7,000 chemicals, many are pharmacologically very active agents which are antigenic in nature, cytotoxic in nature, mutagenic in nature, and they produce cancer. According to the International Agency on Cancer Research, there are 70 carcinogens which have been so far identified and isolated from the body. Metabolites of nicotine, which is the prominent constituent member of the chemicals present in tobacco. Its metabolites can incite DNA adduct formation, gene mutation, and can initiate the process of cancer formation. There is another very important constituent, that is tar, which is present in the tobacco smoke. It's a brown, sticky substance, particulate matter. It is responsible for coloring the fingers and the teeth. Has a long list of carcinogens in it. Cytochrome P450 hydroxylates such as obsessive-compulsive and N-nitroxylamines, they are present as carcinogens in tar, and they say that those smokers who can metabolize obsessive-compulsive, they have about 8 times more chances to develop cancer as compared to those who cannot metabolize. Apart from this, carbon monoxide is very poisonous and toxic gas, which is present in tobacco smoke in the ratio of 2 to 6% of it. It combines with hemoglobin, causing methemoglobin, and reduces the oxygen carrying capacity of the blood and damages the lungs. Similarly, other chemicals like nitrogen oxide, hydrogen cyanide, ammonia, metals like cadmium, and many other radioactive substances, they are all toxic, very highly toxic chemicals present in tobacco smoke which the smokers inhale. Out of all these, nicotine is pharmacology the most active substance which is responsible for number of pathophysiological diseases. It is an alkaloid which has carbon, hydrogen and nitrogen atoms in the proportion of C10, X14 and N, forming a double ring-like structure, and it was isolated by some German scientists in 1828, and in its pure form it is a colorless, odorless, volatile alkaline substance which turns pale yellow to dark brown on exposure to air and gives a characteristic tobacco smell. It's such a highly toxic and potentially lethal substance that if one drop of pure nicotine placed on the tongue of a man or a dog, it will die within minutes. It's such a poisonous substance. It not only causes damaging effect, as I told, there are many carcinogens. It has tolerance to its own action, and that's why it is highly
addictive substance, as addictive as any of the hardcore drugs. How does it act in the body? When it is smoked through the lungs, it reaches the bloodstream. In case those who use the smokeless tobacco, in those it is absorbed through the oral mucosa, nasal mucosa, or through the skin. And from the skin, when it reaches the blood, once it enters the blood, within 7 seconds it reaches the brain. And of course, very fast it gets degraded also. That's why the people have to smoke repeatedly to maintain the same effect. Because once nicotine enters the brain, it increases the metabolism of the brain cells, and it raises the blood pressure, increases the pulse rate. These are the physiological effects which are produced because of the release of epinephrine and because of the release of glucose. And subsequently, of course, it is distributed throughout the skeletal muscles and the brain and activates receptors while consuming. So, once nicotine enters into the brain, it acts on the cerebral system, the prefrontal cortex, thalamus, and the visual system. It binds to various receptors and releases dopamine into the extracellular area of nucleus accumbens and the ventral tegmental area and stimulates the reward circuit on which nicotine acts. They are called nicotine receptors. On the dopamine, there is a mood modulation, mood becomes better, and beta endorphins, which reduces anxiety of the person, and with GABA, there is a reduction in anxiety and tension. So these are symptoms of a stressed person get relieved, and that's why people under stress smoke more. So this way it is convincingly admitted that tobacco is the addiction to this symptom. And in absence of this drug, there is appearance of withdrawal symptoms which are worse in the first 24 to 48 hours. And the symptoms which are generally experienced by the person, first of all, is a strong craving to have smoke. Then, of course, mood gets depressed. There's increased appetite or weight gain with the passage of time. There's irritability, frustration, anger, anxiety, and difficulty in concentrating. The person cannot concentrate in the absence of this, and this is not correct. So, friends, it is an addictive drug, and about 1/3 of the world's population, that is 1.3 billion people around the world, use tobacco on dependent. In the Western world, particularly in Europe and in America, the use has declined in the recent decades because of medical reasons. But it has increased in the developing world, particularly in the Asian countries, and the commercial forces are behind it. They are targeting the adolescent and the children population. No amount of nicotine or no amount of tobacco is safe, as some people say that I smoke 1 or 2 cigarettes a day and that's all. No amount is safe. Tobacco use, as it causes many diseases, it leads to premature deaths, and it is estimated that 50% of the people who start smoking in their adolescence or in childhood will eventually die prematurely. So out of 1.3 billion people who are smokers today will die, out of these 650 million will die prematurely. So this is the magnitude of the problem that tobacco use has. If you look at the statistics, you will see that in 1990, about 3 million people used to die because of tobacco-related diseases. And today, it is about 5 million who died because of tobacco-related diseases. And it is estimated that by 2020, tobacco will become the world's leading health problem, causing 8.4 million deaths every year, and which will be more than HIV, TB, maternal mortality, motor vehicle accidents, suicide and homicide combined. If you combine all these, the tobacco-related deaths will be more than that. So you can see the magnitude of the problem. And if the current trend of prevalence of smoking or tobacco use continues, by 2025 there will be 10 million smoke-related deaths, and 70% of all these deaths will occur in the developing countries only. So that demands for immediate intervention. But cooking is not a matter of just one science. Once the person gets hooked, despite of his best efforts, people cannot generally leave. They will quit. Because there are many other reasons also. Environmental tobacco smoke. You may not be smoking, but still you are inhaling, because if you are living in a family where some family member smokes, and environmental tobacco smoke plays a heavy in such type of family. So, as physicians, what is our role? Apart from the history which we ask from various other things, it should be mandatory that every patient should be asked about his tobacco-related habits, whether he uses tobacco, whether he smokes, or consumes tobacco in some other way. What are the barriers? What are the difficulties in living tobacco? What is addiction? Because there are, within 24 hours, there is the appearance of withdrawal symptoms, person becomes restless, irritated, anger is there, lack of concentration, and to enhance concentration on light. So that is what, that's because of addiction one finds it difficult to live. The fear of weight gain, particularly in women. Women smokers generally smoke because they maintain their weight. It causes suppression of appetite and weight is maintained. So they fear the gain of weight in case they leave it. Then depression is another. You know that depression is 2 times more common in women as compared to men. And smoking is 4 times more common in depressed patients. So the magnitude of problem is related to depression. So if the depression of the person is corrected, smoking will automatically go. And of course stress, family stress, work stress, all these also lead to continuity of smoking in people. So these are the barriers which are creating hurdle in person to stop smoking or using tobacco. We have certain assessment instruments. Against test is one, and out of the 6 items which are there in this test, only one is qualified that when do you need your first cigarette during the day. If the person needs it immediately after getting up from the bed, within half an hour, means he is highly dependent on the record. Then of course management, we have many devices to manage the record. We use pharmacological methods, we have psychosocial or behavioral methods. In the pharmacological method, we have nicotine replacement therapy, we have non-nicotine pharmacological agents which are used. So the treatment would be the first line treatment and the second line treatment. The first line pharmacological treatment we have bupropion, which is a 150 milligrams for the first 3 days. In Indian context, we have freely available on gums and second line treatment, clonidine and noradrenaline are commonly used. So bupropion, I have already told that we start within the dosage of this because it acts on the pleasure circuit and increases the availability of dopamine in the extracellular area of the segmental area, and it takes the place of nicotine and maintains the mood. So because the mood regulating the pressure of withdrawal symptoms and the person is able to keep smoking or using. Varenicline is essentially relatively new drug that come to market and it was approved by the FDA in 2006. It's a partial agonist at the alpha-4 and beta-2 receptors. It acts both ways, as in nicotine replacement therapy also, as well as other drugs like bupropion. So it acts in both the ways, and it blocks the effect of exogenous nicotine when a person takes. So reinforcing effect is attenuated, and the person is quite safe, it can be used, but there are contraindications for this drug, like in case of anemia or in case of seizure disorders. Clonidine is another drug, which is the second line drug, and it's alpha-2 adrenergic receptor agonist. And the main function of this drug is to attenuate anxiety and restlessness. And because of that, when the anxieties or lack of concentration is taken care of, the person can be helped with this drug. Of course, one needs to be monitoring the blood pressure, and at the same time the person should be hospitalized for using this. Some antidepressants like noradrenaline are found to be effective in various trials, and de-addiction to nicotine is independent of depression with the help of noradrenaline. In the dose of 75 to 100 milligrams is used for 8 to 12 weeks. Lexmitrine is another drug. Of course, we are not frequently using it, but it can be used in smokers as it is an antagonist, and it blocks the pleasurable effects of tobacco. And if the person smokes after taking this, there will be no pleasurable effect, there will be no reinforcing effect, and after some time. This is a new product, unique wax. It is still under trial, and it works by stimulating the immune system of the body. Antibodies are formed, and the antibodies get combined with the nicotine molecule which is suspended on the tar, and the size of the nicotine becomes so big that it cannot pass the blood-brain barrier. And when nicotine doesn't reach the brain cells, there won't be any reinforcing effect. So the pleasurable effect of nicotine is blocked by sleep-wake. This is still in a pre-clinical trial, and they are suggesting that they are preparing an injection which can be given to prevent the relapse also, because the effect of injection is said to be longer than that of nicotine. So this is still under trial, and it has not come in the market. Then of course in behavioral therapy you use aversive therapy, dilation, rapid smoking, reduced aversion, contingency plans, social support, coping, and relaxation therapy. Hypnotherapy is also tried in smokers when the person is under hypnosis, suggesting that smoking is poisonous for your body. You need your body to live, and you own your body. So this way you can give suggestions and are going to be helpful in this trial. Acupuncture is another way of intervening. It has also been tried. Then in some cases where the severity of dependence is quite high, we can combine behavioral therapy as well as pharmacy. Combination is also going to be quite effective. Physician's role is very important. 3 minutes advice to the patient on smoking, while the physician goes a long way. This is a documented fact in various studies. You just talk to the patient about the smoking behavior, explore the possibilities of quitting it, and advise to quit. Tell about the benefits of quitting. This goes a long way in contemplating for the patient to quit. Ask about smoking, advise, ask to quit, assist, and arrange. The 5 is keeping it. So, friends, tobacco smoking is a public health problem. It's a public health danger. It kills smokers silently. Not only kills one who smokes, exposes other people also to the risk of morbidity and mortality. And a message to those who are smoking: do not forget that raising sick and
Sir, when we consider the tobacco addiction of tobacco is definitely different from other substances because of its easy availability and social acceptance. I'm just curious, whether the tobacco dependent, people keep on chewing the tobacco, is it just to satisfy their receptors, or is it a learned behavior?
There is a form of smoking, or as smokeless, has been considered to be a social drug. People never recognize it to be addictive substance. If you look at the history, even in the Western world, the recognition came quite late. Only in after 1950s, when the medical morbidity started increasing, they explored whether it is an addictive substance that people have compared with it. In Indian society, this is a way of communication in various communities. So when somebody is ostracized, they say "Hukka pani band." that will not share our hookah with you. So this is a vehicle for communication and it never recognized to be a addictive substance. But with the passage of time and growing awareness, with the emphasis by the medical fraternity that it not only causes damaging effect, it is addictive as well. Now people have started utilizing it. It's a learned behavior also partly because the younger ones learn from the adults. In the villages you will find that majority of the adults operate to smoke hookah. And as the children grow up, as a mark of their growth, or as a mark of their youth, or that they have also become adults, they also start to do it. That way it is a learned behavior. But at the same time, it is addictive. I hope it answers.
Sir, a word about the e-cigarette.
Yes, even the e-cigarette, that is also
We counsel that कुछ कोई tobacco this like give answers that हम क्या करें हमारी जिंदगी में और कुछ है ही नहीं मतलब like that you don't have any other source of entertainment like if you prescribe them medications if you advise them to consult a psychiatrist and then stigma is associated so as per your advice like is there any non-pharmacological therapy to keep them off from tobacco or nicotine dependent products?
They should seek the alternative sources of entertainment rather than going for tobacco. Because once they are convinced that it is harmful to health and at the same time it is also damaging the body system, definitely they will think about quitting it. And that is what has happened in the West. And the prevalence of smoking and tobacco use in the Western countries has drastically reduced only because of these reasons. They didn't use any pharmacotherapy for that. But they got convinced, yes, this is harmful to the health and at the same time addictive as any hardcore drug. And people started because of the medical reasons quitting it. So similar can be done here as well. But because of the lack of awareness, they think that tobacco smoking is not going to harm you in any way. General assumption among people. It needs to be eroded, it can be rectified only by the physician and it becomes a responsibility of every physician who comes in contact with any patient with whatever illness should be asked about the history of smoking and advise about it.
Smoking here got to be done, there's got to be great. And one of the advertisement done by Ranbir Kapoor, आप बारातियों की स्वागत पान मसाला से कीजिए, that's our medium. But now they have realized that this thing is growing up and doing more harm. So now the government of India has increased the custom rate, bed prices and banned the smoking advertisement in media, films, and I think it's also playing a role.
Comes to you and you know that he is smoking and if you ask him now is it giving you the same pleasure as it used to give you earlier, that will dissuade him to persuade him to stop smoking because he is not getting, now he is smoking just because he has to smoke, not because of any peer pressure or anything, those truck drivers that you are talking about. You just ask them whether it really relieves your tension or not now, and how much amount of smoking are they doing or what are they doing to get the same effect. And that way you can dissuade them to not to smoke.
The recent trend of people are coming in the OPD with the dependent on nicotine gums. Recently I have seen 2 or 3 cases. For how long duration such patients should be given the nicotine gums? And when then it should be stopped?
Nicotine gums is quite frequently observed. First of all, it needs to be very judiciously used, not to take an overdose. Because as it is prescribed, that 2 milligram grams should be used for the initial 6 weeks, 1 to 2 grams per hour, not exceeding 24 hours. 24. And then for another 2 weeks, in 2 to 4 weeks, 2 to 4 hours, and another 2 weeks, 4 to 8 hours. One should not go beyond that, because that is sufficient for a person to replace the withdrawal effect which occurs because of smoking. But some people have the tendency to have more pleasurable effect, go for the higher dose, take 2 pieces instead of 1. That should not be, that needs to be monitored, and they should be clearly told, to be educated, that they should not use more, because there are high chances of getting dependent on the concept. Because there is a nicotine after all in that also. But that is safer because it is more refined, it doesn't have other contents of tobacco smoke. That way it is just nicotine which replaces the withdrawal, but at the same time it cannot be used in overdose.
Sir, I have a comment to it.
But if compared to statin, but there have been statin on the children and and there is more.
Any more questions? So in the end, I'd like to thank Professor Jiloha for his extensive talk, and Department of Psychiatry, Subharti Medical College, especially Professor. As I was preparing for my PG exam, I had a lot of anxiety before this. Thanks once again.
Indrajit Sharma to give memento and certificate to Honorable. Thank you, sir. I request Dr. Bhatia to give memento.
That's what I tried. Okay. Sir.
Thank you, sir. Subharti Medical College to start the panel discussion.
And interest in the topic, sexual abuse and rape. It is most appropriately discussed under the heading of aggression. Rape is an act of violence and its sexuality used in its severest form to satisfy non-sexual needs. Sexual abuse and rape. We are privileged to have esteemed panelists with us. I welcome Dr. G.D. Kulwal, Senior Professor of Department of Psychiatry, SN Medical College, Jodhpur. Please raise the dais, sir. Our esteemed guest was honoured by Rajasthan government for rendering free camps for mentally ill people. Our third panelist, Dr. Rajesh Sagar, is a Professor of Psychiatry at AIIMS, New Delhi. He is MN, AMS, FIMSA, Secretary to Central Mental Health Authority, Government of India. Kindly raise the dais, sir. Fourth panelist is Dr. Subharti. We are proud to have him here. He is a former professor and coordinator law, Laksana, Government of India, has worked with Ministry of Health, Ethiopia, Ministry of Education, Ethiopia, and various universities of high repute in India. His area of interest includes human rights, public health, and contemporary issues of global society. We are pleased to have you here, sir. Our fifth panelist is Dr. Mamta Tyagi from Ops and Gynae Department, Subharti Medical College, who has been serving here since 2001. Kindly grace the dais, ma'am. And now I hand over the mic to the chairman of the panel discussion, Dr. N. K. Agarwal.
I must thank the organizers of this conference to give me this opportunity to chair and moderate this session over the most important topic of nowadays, for the sexual abuse and rape. Sexual abuse or rape, the figure which comes in our mind is just like that. A woman is crying and others are saying, and it may be in the form of domestic violence or maybe in the outside. Now, this point is there, which I have received a week back from one of my friends from WhatsApp.
उठो द्रौपदी वस्त्र संभालो अब गोविंदा आएंगे, शोरफ मेहंदी भुजा संभालो खुद ही अपना चीर बचा लो, सूत बिछाए बैठे शपने मस्तक सब मिट जाएंगे. इट इज ओनली प्रेजेंट कंटेस्ट. कब तक आस लगा पाओगी तुम बिके हुए अखबारों से, कैसी रक्षा मांग रही हो दुशासन दरबारों से, स्वयं जो रुझाहीन पड़े हैं वे क्या लाज बचाएंगे, उठो द्रौपदी वस्त्र संभालो अब गोविंदा आएंगे. कल तक केवल अंधा राजा अब गूंगा बहरा भी है, और से तो तुम्हारे किसको क्या समझाओगे, उठो द्रौपदी वस्त्र संभालो अब गोविंद आएंगे. You or may not agree with this context, but this point has been coming with so many. Means you have to save yourself, but society and the other administration has to help this. Now, when we talk about the word rape, now question arises in our mind whether it is stigma which is said to be in society. If a girl is raped and somebody comes to know she has been involved in rape, nobody likes to talk with her, nobody likes to talk and go with her, and sometimes even sit with her. Is rape a disease? Is rape an injury? This question is open to the audience to decide. If a girl is being raped, what is her fault? Is she at fault? So we give her stigma? Or is it a disease? I can say it is a disease in the society, in the minds of the human being. Those who are raping. Not she is suffering from some disease. She is suffering from some injury which has been given by an unsound mind person. This is my view. So it is for all of us to decide whether the sexually abused girl or lady is suffering from an injury or a disease. Now next question arises, which in our society comes, that this particular community is going to rape and this particular person is going to rape, this adult group is going to rape. Does the religion, rapist have any religion? My answer to this question is no. It is only the mindset of any type of person who may be from any community, any age group, from any type of profession can be there. Only the mindset of the person is there who is going to rape. Now this is again a newspaper topic, and we all have in our minds that temple priests and other functions are not going to be involved. Here I am not going to say this particular thing, that temple priests or temples are there, but a girl who has been raped by a minor girl who was raped by a priest said that I am scared to sleep when I see his face. It again gives the opinion that any type of person who we have faith can be involved into rape. Here again cutting minor rape 4-year-old girl at government school. Now, the main problem with us is in which not only one or the other involved, everybody is involved. No onlooker comes to give the evidence for that girl. Even they know that girl has been raped by a particular person, they may say that I was not there, I am not know, or whatever way they say, and they are not getting to want to involved in that. Now in relation to this sexual abuse, few terms are used. I have just listed 4 to 5, but all these terms have more or less same meaning with little difference. Now, again some myth is there, sexual violence or abuse just means rape and child abuse. No. When we talk about sexual violence, it includes everything. I have given so many things in this slide, and this is an incomplete slide, I can say that so many things can be there, so many ways can be there in which a girl can be exploited in our society, in our houses, in our workplace, or anywhere, in the movement, in the buses, or anywhere. Now, sexual violence is not a problem in any community. When I use the word community, it does not mean Hindu or Muslim, it means any profession or any age or anything. It involves worldwide. It again question is same, which I have just said, that it involves the whole of our societal risk and sexuality. This is the point of discussion, mostly children, and up to 50% of reported cases are usually in adolescent. Children with weak family ties, low family income, children with sexually aggressive friends who have witnessed or experienced violence, and a who will use abuse of drugs or alcohol may be at risk. Again, this is a girl, this is Sandy Padi hai, like this, and we say that 1 in 5 girls and 1 in 20 boys is a victim of child abuse. And when we know this, then we all have to work to stop the child sexual abuse. Now, how the WHO defines the definition of sexual violence? Any sexual act, attempt to obtain a sexual act, unwanted sexual comments, advancing an act to traffic or otherwise directed against a person, sexuality, manipulation, threats or harm, or physical force by any person regardless of relationship to the victim in any setting, including but not limited to home or birth, is sexual violence. Now, the crime of rape is a major problem in India. The acquittal rate is very low. I was reading one of the newspapers that if 100 persons accused of rape are being arrested, lastly after trial only 5 to 10% or even in some cases 50% are only convicted. So you can say that what will happen to the rest 85% who have been alleged and raped in police custody. This may be due to victims do not file a complaint and most of the cases remains as unreported, poor evidence gathering and lacunae in the law. In India, I have got this figure, but I am not agreeing with this figure that one rape is committed every 29 minutes. If I will agree also, then I can say that this figure is very low in the tip of the iceberg. Only very few cases are reported and most of the cases remain unreported. And again, very few of the accused are convicted, 20-30%. Conviction depends on the medical examination performed by our colleagues and evidence collected during examination, and it is physician's duty to examine the victim and accused properly and to collect all the necessary evidence. Then reported cases in Delhi, again it is very low as compared to actually what they are happening. Now, somebody said in villages so many rapes are occurring, and one of our colleagues, that Videshwar Pathak, founder of Subharti International, has said the absence of a toilet in a house is sponsored by incidents of rape and sexual assault within. But if it is one, we can say that why sexual violence or rapes are happening in urban areas, like cities. I can say that incident will go. Just give the history, you must be knowing that Criminal Amendment Act 2013 was enacted last year. It happened after when a girl in 16 December 2012 in time was beaten and gang raped in Delhi, and she died from until 13 days later. Dispassionate coverage and condemned by all the agencies stressed for women's rights. Public protests take place in Delhi and other cities in the country where thousands of protesters were released. On 2nd December, a committee was formed by the government. You must be knowing that under the custom. Okay. 2013. And in this act, mainly the definition of rape has been changed. I am just going to the main points. My law colleague is here who can be able to tell. Definition of rape under section 375, the word has been included, sentences are included. A man is said to commit rape if he penetrates his penis to any extent in the vagina, mouth, urethra or anus of a woman or makes her to do so with him or any other person. There the word mouth or anus has been added in this just to any extent any object as a part of the body not being the penis in the vagina, urethra or anus of a woman or makes her to do so with him or any other person. This has been done keeping in mind the October
December 16 incident, and subsequently one more incident when a small child of 5 years under whose vagina a bottle was inserted. And previously these things were not under section 375, although they were taken as sexual violence. Manipulates any part of the body of a woman so as to cause penetration to the vagina, urethra, anus, or any part of the body of such woman, or makes her to go so with him or other person. Secondly, he applies mouth to the vagina, anus, urethra of a woman to make her to do so with him or any other person. All these stanzas are falling in any of the following. This is about more or less the same. The only thing which has been more provided is that instead of the age of consent by a woman, which was previously 16 years, and it has been raised to 18 years after this criminal amendment act, that a woman of 18 years or more can give the consent for sexual intercourse. And below that, she cannot give the consent for sexual intercourse. And in the section, some exceptions are there because the medical practitioner is also doing some procedure for intervention and touching and doing some investigation that will not constitute rape. Sexual intercourse or sexual acts by a man with his own wife, the not wife under being 50 years age, not rape. Now few sections, things has again been added under the Criminal Amendment Act, but in this the punishment has been increased for the government servants, and this punishment for potentially causing grievous hurt by doing the sexual violence has been increased to 10 years. And then one more thing has been added under 326B, in which the voluntary throwing or attempting to throw acid, in case of habitual age, which was increasing day by day. To disfigure the face of a woman, they were throwing the acid in her drink due to some accident. That has been added, and in this imprisonment of 5 years, but it will never exception to 7 years has been there. Then the punishment for voyeurism and stalking, which was not there previously, it has been added. Now this is again a figure showing stalking, peeping Tom, voyeurism, and touching in a place which is not a part of our society. Now, previously I am just trying for my other speakers as to speak. Then something about the domestic violence act, which has been added in 2005. It literally meaning, simply speaking, it means violence committed by a member of the family against another man. Here the term domestic has been used as an adjective. It pertains to home, family, household. And here is a figure showing a woman who has got domestic violence. And section 498 and 304B related to body deaths is actually well-known old ones. And this, on the basis of this, the Protection of Women from Domestic Violence Act were added. And what is this? It is a piece of social legislation passed by the Parliament in India in August 2005. This came into effect on 26th October 2006, and it extends to all of India except the state of Jammu and Kashmir. Now, salient features of this act I will go. It seeks to protect a woman from domestic violence committed or threatened to be committed by an adult male member of the family. It recognizes the right of the accused woman to reside in the shared household. A grieved woman may directly apply to the magistrate for appropriate relief. She may also approach the magistrate through other agencies such as protection officer, which has been appointed by any law area. It is for the protection officer, police officer, or service provider to aid and assist the aggrieved woman in seeking the appropriate relief under the Act. And then some counseling and disposal is there. Now, some persons are saying that there are so many acts for the woman, why not the acts for the men? In a study I was reading, in this paper cutting, if you go into the para in second line, second column in second or third paragraph, it is there. Of the 22,091 arrested under section 498A, only 7.9% were convicted, with the life of the 92.1% falsely arrested remains the same. So this is the question, that again husband suicides are more than the twice that of women suicides. Husband suicide they have beyond 64,000 and wife suicide they have beyond 21,000 over the last 20 years. Family issues and not financial troubles were the major cause. Here again this applies how the woman can hurt. Many men have threatened by brother-in-law, father-in-laws to act in their own way, take all his earnings, refuse to entertain husband's family or not look after their own parents, force men to pay for wife's family but stop monetary help to his family, in India there is no law to safeguard women against domestic violence. Now few words about the sexual harassment at workplace. This Sept has also come into force in December last year. What is sexual harassment at workplace? It is a form of sex discrimination that involves unwanted or unwelcome conduct of a sexual nature. This applies to harassment by a person against another person of the opposite sex. It affects the confidence, personal dignity and peaceful environment at workplace. Generally, sexual harassment is sexually oriented conduct that may endanger the victim's job and performance. This can be in the form of a person working at workplace. It is not only the government hospitals or private hospitals or medical college. Verbal comments over the females, inappropriate gestures, physical contact and advances, a demand or request for sexual favors, showing pornography, and any other welcome physical, verbal or non-verbal contact of sexual nature. In 1997, this case of Shaka judgment was there versus state of Rajasthan. After this, these type of sexual harassment laws were initiated, and according to this, the National Commission for Women in 1998 has given following as one of the behaviors which can be taken as the sexual harassment: ill-meaning, unsavory remarks, jokes causing or likely to cause awkwardness, innuendos and taunts, gender-based insults, unwelcome sexual overtone, touching or bruising, brushing against any part of the body, displaying pornography, possible physical touch, visual confinement. Recently, you must have come to know that a law intern has filed a case against his senior colleague, and this has generated a lot of criticism and favorism from any side. And this is Rebecca, is some senior advocate said there is deep-rooted institutional bias against women in the judiciary, and this is some of the things about the Sexual Harassment Act. In the course, gender bias is reflected in the sexist language during the judgments. It is much harder for women to rise up the ladder. They have to work harder to prove themselves. This again said by the same senior advocate. And another person, former professor of law, has said it was very hard to gather support for the law intern who had accused Justice Ganguly. Law school need to take a strong stand in such matters. And some retired High Court judges said in the same case, in this profession, women have to be doubly prepared and convey that the mean business today, women are coming up in a big way in the legal space and doing their work. And what cutting which I am showing you, we should try to stop rape and not just avoid. I was reading one poster outside this hall in the How to Prevent the Sexual Abuse and Rape, which I written by some students of this college only I have seen, made by them. That was mainly showing how to avoid that. And that's good. One should avoid and one should try to save herself. But our society has to work to stop these things, sexual abuse and rape. We have to do something. That females should be free to walk in whatever way they want to walk and live, and they should not try to use any mode to save themselves. And why this delay is there? It is said that shortage of female officers affecting speedy rate progress. This is something which I was reading here. Now, housing open to my colleague.
Panel discussion. So, but I think we had a very good presentation by Dr. Agarwal, and that sets the tone for the panel discussion. Now, I would rather, thank the organizer for of course, inviting me for this, though it was a short notice, and two, for choosing such an important topic. Like when we see the theme, the neglected issues in psychiatry, I think this is one of the important areas. And rarely, I think we talk about or we discuss about, sexual abuse and rape as such. We do not talk about this even in the mental health professionals. So that's a very good, I would say, beginning. And I would say, I will also talk about what the developments are being taken up, in Delhi specifically. And what I would talk about what my specific role has been, and because Dr. Agarwal talked about that, the unfortunate case of Nirbhaya, you are aware of that. After that, Delhi government chief minister had constituted a committee, and asked chairperson of, there is something known as DCPCR, that is Delhi Commission of Protection of Child Rights. Now in that, there was a chairperson, Mr. Arun Mathur, who was called and was asked to develop a guideline for the child abuse, guideline for the prevention of child abuse. Now, which is there in the website. If you go to the website of DCPCR, which is there, it is about 170-page document, and and there was a core committee. Now, this core committee constituted of people from law background, activists, child welfare committee, and from legal expert and so on. But there were only 2 medical doctors. I was one of them because I was invited to be in that core group. Another one, also a doctor, Dr. Agarwal, who was basically a administration side. So practically, as a clinician, I was the only one in a group of 10-15 people. So you can understand that it is not being given, doctors are not being given due importance in such a committee which is being formed. This basically was driven by a legal expert and so on. So I was one of the core members, and this is about 170-page document, and I have been talking about these guidelines in different forums. In fact, in Psychiatry forum, in our national conference, I had made a symposium. In fact, in a legal medicine conference also, I made a presentation. So in last 1 year, I have made several presentations just to make people aware of it. And so that's one area which my role has been. Another is, you would be aware that UNICEF and IMA also has taken up this task of child sexual abuse, CSA. Now, I don't know how many of you know this. Last 7th June in IMA, it was a big symposium was organized, and a lot of people had come, and the UNICEF has taken up in a big way, and this was a symposium. Now the latest development is that the project has been launched by UNICEF, and it will go in the pan-India. That the training will be provided, and some of the people who are involved with this work are there, and there will be training for people for the medical colleges in different 4 zones. They will be identified. There will be training for trainer and so on. So what I'm saying is that some developments are being taken up, in this particular area, especially for child sexual abuse. That is. So which is an important area for us to understand. So what I will just highlight in that context that we know that, as Dr. Agarwal has mentioned, that children are one of the major group which we need to focus on. And we all know that country like India, the population of children almost 40%, 40 and above, and you'll be surprised to know that in the world, in India, person as a whole, mentality of the society as a whole. It is not the psychiatric illness, or it is not the psychiatric part only. It comes later on. But to start with, if you look at the psychological development of a human being, every human being is born with some inborn desires, inherited desires of sex, air, hunger, and thirst. Everybody have desire for sex. Everybody wants sex. Then comes the Freudian stages of psychosexual development, id, ego, superego, and other defense mechanisms. Because everybody is there in the world, born with the inborn desire of having sex, that is id. But id is the only pleasure principle. Then comes the ego, development of ego. In languages we used to say, इसका ego बहुत कमजोर है, इसका ego तो ऐसे ही है, like that. False ego, pseudo ego, inflated ego, like that. Ego is based on the pleasure, this reality principle, and then comes the super ego, which is a moral value given by the society and parents, conscience, अंतरात्मा की आवाज, like that. A person, why he is being raped? Because everybody is having it. Everybody wants to have sex. And as a human being, man is a person who don't get gratification from the things we he gets easily. So he wants more things from some efforts. So when it comes into the domination of the person in psychology, he wants, but because ego and superego prevents him from doing the wrong things against the society or not accepted by the society. But in certain peoples, the superego is very weak. And sometimes in situation where some catalytic factors operates, person feels that it is more dominating over his ego and superego is not there at all at that time. And that pleasure principle needs immediate gratification of something, particularly of sex. He does a particular act of sexual assault or sexual abuse or sexual rape. Then comes the mentality of the person. Mentality is not framed in a one day. So the mentality will not change in a day. Mentality means, I want to say that mentality of having so many things like we believe, or because as we are seeing in the daily life, most of the families, most of the people, they prefer male child than the female child. Why? Because female child is a liability to him, his family. Grow up her, marry her, and send to some other family. So huge amount of money and efforts are given to the female child, and after getting married, nothing is returned to him. On the other side, there is a risk of getting family insult by some love affair, love marriage, or sexual assault or rape, like that. Another mentality shown by the different pictures, advertisements, books. Because nowadays we see that if a particular incident of rape is occurred or a sexual assault is occurred, most of the media channels, they show them repeatedly, just to get the more viewers, so that their KRP can be increased, so that they can get a more revenue. And this type of mentality, another factor, that easily availability of the mobile phones with porn movies, with other sexual active acts, in the, easily available, cheaply available mobile phones, particularly to the young generation of the society, the growing mind of the society. Then again, mentality is that most of the societies, despite their different beliefs, they believe on a common thing, that girls should be controlled. They should be kept in control. They should not be allowed to go in the society. They should not be allowed to work independently like that. This is again the part of mentality. So there are so many other factors. We will discuss it later on as discussion will further move. Then these are the mentality factors which are sometimes responsible, or rather we can say most of the time responsible. Sometimes people say meaningless things, we can say, the dress of which girl, late night walking of the girls in the market, late night movies like that. These are the provoking factors. It is not the provoking factors. It is the weakness of the man, that he feels that he will lose control over his mind for the femininity, and he will commit some act which is not acceptable to society. So there are many other factors. We will discuss it on later.
The society which is degenerating, and now I request my colleague Dr. Vaibhav Goyal, who is a former professor of law, to give his views.
Who is the victim and who is the offender, as you stated, that we have to discuss and we have to start a discussion. I would like to raise some issues, and rather my presentation will be on brainstorming at what actually we are doing, where the problem exists. Because we are talking something that we have to eradicate the problem, we have to stop it. We are not going to reduce the issue, but we are going to stop the problem. Just by the treatment of a victim, can we stop the problem? So I would like to start with the certain established facts. And our fact one is that we are not a member of a just society. as rightly stated that we are willing to have a male child in comparison of a female. So we are not the member of a just society. Another, our conviction rate is nominal. It is in between 4 to 5% in India. And here I would like to quote, once in Japan there was a difference of 0.1% of the conviction rate. Then there was one committee that why this is 0.1% has been reduced. And over there conviction rate is more than 96%. And third one is that we are not talking about malicious prosecution. Because reporting is over there are the many factors which are working behind that why conviction is not over there. Certain time that malicious prosecution is one of the factors, and there was no prosecution at the time of malicious cases. So this is another issue where we have to think. So my broader outlines of the presentation will be sexual assault, statistics related to sex crime, impact of the sexual assault, steps required and suggested. Here all the statistics are from United Nations Organization website or regional organizations website, and if any other thing then I have mentioned over there. Our society has done a fantastic job of teaching the rape survivor to blame herself or another person's violence. This is the fact of our society. I am not a medical professional, I am simply a lawman. Law means a medium through which society is running. In our day-to-day life, we encounter with various principles of law. This way or that way. We have bundle of laws. Whether this bundle of law can solve the problem? After this committee of late G.S. Verma sir and this rape law has been amended, whether there is any change of the crime rate, I don't think so. As a lawman, I don't think so. Another proposition, if a woman dressed like this was raped a believer in a just society, would most likely blame the victim, not the rapist. What do you think? Because in our day-to-day life, when we come across with the khap panchayat, with the dress sense this way and that way, because the issue is neglected issue of the psychiatrist. That much biological sound, mentally sound, psychological sound, that she is in a position to give the consent if she is 18 plus. Sorry to say, I am not agree with that amendment of the law, and I have sent my proposition even to the committee, and afterwards I have sent my suggestion to the committee that but where we are approaching, whether we are going to control the situation, curb the crime, or simply we are giving a short-term remedy, and just like we are giving I would like to say normally as a punchline, we are giving simply the lollipops in the hand of the public at large to our Indians. Short-term solutions. So, what we mean sexual assault? Sexual assault is an intentional sexual contact characterized by use of force. Here I would like to put a stress, force. When I am using the term assault, that includes force. By use of force, physical threat or abuse of authority when the victim does not or cannot consent. What was the requirement of the Domestic Violence Act? Because authority is over there in between the husband and wife. We are just increasing the number of laws. And within house, if the husband is forcing his wife for the unnatural sex, then it is a sexual assault. If we are talking something about the protection for the rehabilitation with the help of the protection officer, that she must be protected and she must be kept in another house, then there should be no criminal liability, and there is no requirement of a criminal law. Where we are approaching just certain issues which I would like to point out so that we can develop this session, because it is a session for the panel discussion. Until and unless there will be no brainstorming, we cannot initiate the panel discussion. For the purpose. Second is sexual assault includes rape, unconsensual sodomy, oral or anal, and so on. And when one of the following conditions may exist, as all of you are aware, even already discussed, force even if there is no price or injury, fear even if the victim did not fight back, a person is disabled and cannot give consent, a person is severely intoxicated or unconscious as a result of drug or alcohol. And certain non-physical sexual assault is also over there, the threat of violence, threatening to tell that they had sex if they don't. Here I have to just stop for a couple of seconds. One time victim and next time try to tell that they had sex if they don't. Such type of cases are more, if you would like to see in the rural background, such type of cases are more. Tracking towards self if they don't have sex. If I am talking about this, tracking towards self if they don't have sex, I am talking about, non-stranger persons. When we are not a stranger, when sexual assault is by one non-stranger, then this matters a lot, tracking towards self if they don't have sex. As per the definition of the sexual assault includes all the things which have already been discussed by our chairperson. Certain data which I have collected, victim and suspect gender factors, 95% females, 5% male, and so far as the suspect is concerned, 99.9% male, 0.1% female. Second, non-stranger assault, age factor. Here I am talking about the age factor, and you can see the majority of the cases are in between 14 to 18, So they have raised the age from 16 to 18, but what about others? Because we are not talking about to reduce the age. Strangers are responsible for the sexual assault, and who is the non-stranger? Boyfriend. I would like to say that in whom you can develop your faith and where you can show that you have confidence that you can move with that non-stranger, and you are thinking that that person cannot cheat you. So far as 2005 to 2012 sexual assault statistics are concerned, this is before you. You can see the raise of the data that how the statistics are changing and the activity by the non-stranger are increasing day by day. Sex crime by type, and 43% is under the category of rape, and second one is sex with minor. Location. Why I am sharing this data with you? Because when I am talking about neglected issue in the psychiatry, when one patient is coming to a doctor, I am not a doctor, might be possible that I am wrong, but and victimology. We are talking earlier, I think about 40 to 50 years back, we have not discussed in law in detail about the victimology, but we are talking about the psychology of the victim and about the rehabilitation and the grooming of the victim, how the victim can survive in a society, the survival of the victim. So the topic is related with the criminology, penology and victimology. So we have to see all the factors behind, not only with regard to the victim but also associated with the offender. So location, this matters a lot. 58% residence. When I am talking 58% residence, first thing, whether family members are responsible or not, we have to ponder upon, we have to think upon, we have to put stress whether we are giving that much environment within our family that they can be in isolation and they can get the separate room, how much we are interacting, why this data is increasing day by day, what are the factors of the grooming of our children, how we are living and this training and otherwise grooming our offsprings, and hotel and motels. Responsibility of the hotel and motels is equally matters a lot, because how they are having the ID proof at the time of hiring a hotel, when they are giving a hotel to the school going children on the basis about the adolescent and adult. Because until and unless we are not aware about the psychology of a criminal or the offender, the root cause is the offender. If there will be no offender, if there will be no person who can commit a sexual assault, I am sure there will be no data with regard to the sex crime. I think all of you must agree with me and you are with me. And the second, sex crime by the day of week. Sometimes it seems that how it is relevant with this psychological aspect, but we have to see about our leisure and free time, about our schedule, where we are giving time to our offsprings, where they are free, where they are going for outing, and about the timing, and there are so many issues which are associated. Use of drugs. Now I am talking about the impact of the sex assault. No longer feel safe, loss of control over life as it was before, loss of self-worth, feeling demand, damaged, isolation, loneliness, distrust, don't feel safe with anyone, guilt, must have done something to provoke the attack. And certain impacts are there: failure, shame, humiliation, anger, outrage, fear, embarrassment, depression, sleepiness, phobias, fear of, there are so many, impacts of this sex assault, and stages of adjustment, how a victim adjusts himself in this so-called not a just society. Because ultimately, it is established that the conviction rate is very low, not the 50%, even it is not the 50%. 70% cases are unreported, 30% cases are reported, lack of the evidences. Investigation, at the time of the investigation, questions from the investigating officers. Sorry to say, even from the female police officers. There was discussion that some police officers were supposed to be in the panel, but unfortunately some officers are not here. But I have discussed the issue, and that IPS officer is from AIMS, he has done MS from AIMS recently in 2013. He has been, selected as IPS officer. He is my trainee last year, and I discussed the issue with him, and he said that, sir, at the time when there was a point of interrogation with the police officers and with the female police officers, the way they talk, they feel offensive and they cannot disclose that how they have been raped, what was the factor and why they didn't die. Again, the point is that biologically whether the female is that much sound, and again the factor that if you will not have the sex with me, I will hurt myself. And there is some connectivity with different type of connectivity when I am saying that most of the cases are because of that non-strangers. And further, that victim of the sexual assault are 3 times more likely to suffer from the depression, 6 times more likely. I think data can be justified and they can ratified by data because they are well aware. 6 times more likely to suffer from the post-traumatic stress disorder, 30 times more likely to abuse alcohol, 26 times more likely to abuse drugs, 4 times more likely to consider suicide. Day before yesterday, I was reading our newspaper and there was one news. 1 in the 10 are raped or sexually abused worldwide. The data is from your website. Day before yesterday, I had gone to the news, and 10% is reported data. Unreported, you can just imagine, and you cannot say that entire statistics is different in developed country. Because mindset is entirely similar. When we are talking about one Homo sapiens species, then major factors and main characteristic element of the human beings are almost identical. Mindset of society is almost identical even in Christian society, in Islamic society, but I have to say, even in Islamic society, they are more cautious about revealing the facts. So we have to take care about the global society. We sometimes feel that it is only in our Indian society. It is not like that. The problem is equally severe in the entire global society. We cannot say the problem is over there in rural society, not in urban society. In urban society, the adjustment factor matters a lot. They learn how to adjust and how to cope up with the problem. That is not with the rural society that sometimes they go more in depression and problems are over there. What kind of a problem is sexual violence? Whether it is a problem of law. As a lawyer, I will say no, certainly not. It is not a problem of law. Because if it can be considered as a problem of law, we have bundle of laws. Why the problem is increasing day by day? I feel that problem is related to public health problem and violation of human rights. Human rights undoubtedly partially associated with law, and profoundly traumatic personal experience. How? We will discuss at the time with the help of the questions during the panel discussion. And certainly yes, we have to discuss the involved parties when we are talking about the sexual assault. We have discussed the victim and the offender. What about the parent of the victim and the wrongdoer? The parents of the wrongdoer, here I would like to stress upon the parents of the wrongdoer. And the criminal justice system, where investigation, collection of the evidence, though the proceedings should be in camera. Camera room proceedings are refunded as per law. But how much proceedings are camera room proceedings? Not 100%. Sometimes that victim is not aware that it should be in closed camera, and proceedings are in open court. Sorry to say, but it is happening every day. And last but not the least, society. Even if I am talking about neglected issue, then this has been highly neglected even today. Because we have to change the mindset of the society. The gunman has not committed a crime. She is a victim. She needs protection. She needs care. Whether she will get the protection and care within the fences, she will get the protection and care within the family, she will get the protection and care within the society. We are talking about the India and about the global society, rather a impossible phenomena, what I feel. Personally, it's my one more opinion. I am not offensive towards anybody, but it's my one opinion. So far as the rape effect is concerned, I think it is easy to understand. Individual, not that much, but relationship, more severe. Community, much more. And so far as law and order and society is concerned, the figure is before you. And you have seen the impact of Divya case. The matter was related with one individual. How the picture has changed and taken the shape that the matter is related with the entire society, the entire community. The matter is related with the law and order. They compared to change the law, where I feel personally as a man of law, individually I feel there was no flaw in the law. In the various pronouncements of the Supreme Court of India, they have clarified what means sexual assault, what means rape. We do have even a provision outrages the modesty of a woman. But so far as reporting of the offence, that what you mean, how many offences have been reported as outrage the modesty of the women, I try to collect the data. And from the September to March 2014, and the data was shocking, nil. From the 12th district, I demanded the data because my trainings were over there, and I asked them to send the data about the FIRs and the complaints or non-cognizable reports with regard to the outrage the modesty of the women. The data was there. Who is responsible? And where we are going? The cost of the sexual violence is not only to the individual, as I earlier told you, to the relationship and the society. And there are various issues which are the part, but I would like to further put stress over certain issues. In past, one steps has been taken that first war crime tribunal. There was the first war crime tribunal to the best of my knowledge. It was in 1940s, which has been established after Second World War in Tokyo and Nuremberg. And one major factor for the tribunal that was mass rape played an important part for the creation of this war crime tribunal. On the website of the Rome Convention and the Rome Statute, this can be, just ratified. So far as the present situation after the Divya case and at the time of the Divya case is concerned, lead prosecution in a special court, but there was a great agitation for the Reed's amendment in the law, but no avail. But data speaks no impact at all. It is the data, but I would like to say there is an impact in a negative manner. You can say that reporting is much higher, but I would like to say it is not like that. Media is highlighting the facts, and sometimes the person who has some criminal instinct, which is psycho, that he wants to get famous in a society. So that type of whether this type of news should be reported in the newspaper, we are talking about the report through media and report to the police officers, report for the purpose of justice. We have to segregate these two issues. We are saying reporting is higher because it is in media. We are not clarifying whether it is in the criminal justice system or not. We have to check it out. And I would like to say marginal differences over there. In reporting, there is a big gap, huge difference. But so far as in the police stations or otherwise, marginal differences over there. And so far as the future is concerned, what I feel, the role of doctrine at the time of the formulation of the law and policy, specifically psychiatrists. And they have to be called, and their opinion must be taken, and not only their opinion, but major role. Because they are aware about the mindset of the victim as well as if there is a problem in the psycho of a offender, then they can tell and they can give a better solution. As you know that I feel that a doctor can give a better solution, but sorry to say, the role of the medical professionals, as Dr. Sagar told that two doctors were over there. So role of the doctors are not that much as it should be. Another issue as it has been discussed at a different level, curriculum development, but my point is slightly different at the primary and secondary level. some inputs and some education, value education with regard to, with regard to the psychological aspect and with regard to the rehabilitation techniques and with regard to how to report and how to make self stronger and stronger and easy to heal at early stage. It is said by Miss Mariska, and she was really an activist. She is working for the purpose of, cure the problem of this, sexual assault victim. And even she has stated further that the problem can be diagnosed even at the time of childhood. As rightly stated by Professor Kulwal that, it is not a problem, medical problem. But when we are saying that there are certain instincts in the mind that we have to do like this and we want to achieve like this, and when I am going to crack the elements of a crime, then mens rea is a major element. Mens rea means mental element. When I am talking about the mental element, meaning thereby, there is a motive in my mind for the purpose I am committing a crime. I have discussed, at one of my empirical study with certain offenders who are behind the bars that why you have committed the crime and what was your mindset after the commencement of crime. The opinion of the majority of the individual that they said that we feel guilt. हमें बुरा लगा, हमें लगा कि हमने कुछ गलत किया है. And we are ashamed, but again we are convinced हो गए. I'm just telling their words. अगर एक बार punishment मिल गया, then society will accept that we are the rapist. So even this type of mindset is over there in the mind of under trials. And here even I have gone through one article and I am with the same opinion. Fixing the responsibility of the parents. Though it is tough in the criminal law because we cannot make responsible their parents in criminal law for the act where they have not participated. But so far as the recent development in law where we are talking about the compensatory jurisprudence. Through the compensatory jurisprudence, we can fix the liability of the parents. Because when we are talking about the parents, when we are talking about the society, when we are talking about country as a whole, the problem is associated with the law and order. The problem is related with you and me. Then ultimately, why not parents are responsible who is not giving the value education to their offspring? Last but not the least, I am going to say that they are the three wings. If these three wings are all together, these three wings are not working in a segregated manner or independently or not in a joint manner, then we will not get the result. But if these three wings are working in a in a coordinating manner, a joint manner, and like the slide is showing you, and three wings are healing and wellness, policy and advocacy, education and awareness. Thank you for the time and thank you for the invitation. And
after this terrible case, reporting of these sexual abuse and rape cases is increasing day by day. And so naturally we will again to talk something. Now I will request Dr. Mamta Tyagi to use on this. Our parents should only talk something about it, who might be taking the victims of rape and sexual abuse to be done.
Thank you, Dr. Abdullah, to give me the opportunity. The problem is solved. So before coming, problem is under the court of the doctors, and you gave the problem to the law, and I think Vaibhav, a very good speaker in this institution, solved the problem what I want to convey today. But मैं इस बात को दूसरी तरीके से करूँगी. As a doctor and Dr. Mamta, once we see the patient, our duty is what patient want to convey. That one is pain. As a doctor, as a gynecologist, we examine the patient. Not only in our field, what is there in the genital organ, there any abrasion, any lesion there, and we should consider, because the rape is not a diagnosis given by the medical person, it is a diagnosis by the law. So, and we should consider the various facts that we examine the external organ, we examine the vagina, the uterus, and the other thing, and the other reasons which are present in the body. But once we give the diagnosis, before we should consider that more than 10% of the male they are azoospermic or oligospermic, may be motile or not, and simultaneously, so we have to take the sample from the vagina, from the cervix, from the urethra, and we should see that what problem she should have at present, the surgical problem, the trauma problem, and what trauma she can have later in the life. That is the
psychological trauma which bed cannot suture at that time. We can suture the tear which she is having, but we cannot suture the trauma which she is having in their brain or throughout her life. The follow-up is very, very important. We have to follow up the patient because that person is very likely to have the HIV, the sexual diseases, STD, what we all know. But a very small thing which Mr. Vaibhav has said clearly in a very small mind, जब से कुछ cases होते हैं, I have every thought when a child is born in the labor room, whether it's a male baby or a female baby, उसके mind में प्रॉब्लम नहीं होती कि वो क्या बनेगा क्या नहीं. It's our parents, as a doctor, as a parent, as a part of the society, or is a male because she is the first person to see or look after or responsible for her kids, and then the neighbors, the society, the friends, and the doctors and the teachers, and with whom he or she is coming in contact with. So problem is not that is an incident which is happening, that is the rape is happening, and the person or the couple is reporting. Can we solve? Can the problem be solved in the court? As the doctor has said, no, it cannot be, because अगर हमने as a माँ उस बच्चे को सिखाया हो कि उसे क्या करना है, अपनी फीमेल बेबी को ही सिखाया है, या किसी अपने हमारा बेटा है हमने उसको सिखाया है, as a neighbor हमने अपने किसी नेबर के बच्चे को कुछ गलती करते देखा है, अगर हमने उसको समझाया है, और when we are going in the road, some boy is passing the comment on a female, or we bypass the, because as a social person our responsibility is there for the society. As a teacher, when we see a student, delivering a lecture is the part of the teacher's responsibility, but because these kids are away from their parents, they are in the hostel, again it's a responsibility of us as a teacher, as a guardian, that so this problem can be solved at different levels, at the home, at the neighbor, at the society, at roadside, at the college, and other places. So that ultimate culmination is there. So if we want believing prophylaxis, prevention, precaution, so we have to take measures at different level, and then only the problem can be solved. Blaming one person for that reason is no way. Suppose a boy does this and उसके दिमाग में ये प्रॉब्लम आई कहाँ से? क्या उसने अपने घर में कुछ सीन देखा, पड़ोसी में देखा, सुना, और he is frustrated, or he is right person, but society is not accepting him as a right person. If he does the right thing, make it possible, he may not be rewarded or said that you are doing the right thing. So that frustration comes from so many things, from home, from society, from the workplace, and otherwise from senior and colleague junior person. So the problem is that is an incident is happening. तब सब strike करते हैं, तब सब question raise करते हैं, sitting in the car, sitting in the AC room, sitting in the chamber. The problem is not at one point, that is the end point that is happening. If we want to solve that problem, we have to take the precaution at miles back. So a reasonable act which is there in the nature, who has made that a punishable act? The thing is that we should all think.
I have some issues regarding this phenomena of social phenomena of rape. If you look at the National Crime Records Bureau of 2013, 24,923 rapes were reported in this year of 2012. Out of these, 24,400 were committed by the people who knew the victim, which 98% of the cases were by those people who knew the female. Either they were related, or they were neighbors, or they were students, or whatever. It means the mind of the people who committed crime had a very well organized plan to commit the crime. So this opens a very new front. Is this really a crime which is well organized by people, or it comes at random? That is for the mental health professionals to ponder over it. Why this crime occurs? That is one. Second is, if you look at the prevalence rate of rape, India stands the second lowest in the world. First is Japan, where it is 1 per lakh population per year. In India it is 2 at the moment. Highest is in South Africa, where it is more than 114 or something. So it means if we compare with other countries, the crime in India as far as sexual assault is concerned, it's not very alarming. But at the same time, it has to occur because of the uniqueness of human mind. Human mind can never be crime free. That is second. Third is that the new ordinance which has come up in 2018, it has made many improvements as compared to the original law that was in Indian Penal Code of 1860. According to 375 section, if a person has had sexual intercourse with his wife who is not less than 15 years of age, it is not a rape. That's what this act says, section says. It means after 15 years of age, a person can force his wife to have sex irrespective of the fact whether she likes it or not. So that is a marital rape. And if you look at the statistics, 2/3 of married women in India are victims of marital rape. But this ordinance didn't take this into consideration that marital rape should also be under the ambit of crime. With the reasons mysteriously known to the expert, why it was excluded, where in most of the Western countries it is included as a crime. Next is about gender. As far as the gender specificity is concerned, this new ordinance has made it gender neutral to say that any object which is inserted by or any custodial rape, when someone comes rape, whether it's man or man to man or it's woman to man, that's a crime. But nowhere it is written that if the woman commits rape on a man, is it a crime? Why not? It's not a new phenomenon. If you look at the literature in the West or in America, you will find that at least 1 out of the 5 rapes are committed by women or men. And that's not a crime. That's nowhere specified in this new ordinance of 1930. These are the two of the issues which need to be pondered over and to be discussed. Thank you.
8% of cases, strangers are mainly involved in causing the rape and are the accused in rape. It means it is organized crime. We all must agree with this. It is one of the things a stranger or the rapist is thinking, might be thinking from so many days and so many days. He might be trying to take himself in a position so that he can have the time to do this sexual act. This is one of my views. I will take the views of my other colleagues also. Secondly, sir has said about the lower spending to increase or decrease the crime rate in our India. I agree that our government should encourage, and it is gender neutral. Why men are only involved or said to be punished for causing the rape, why not doing this? So first I will ask my colleague to give the answer.
If a boy is committing rape, if a man is committing rape, they feel if they are within the family that they will get the protection. Nobody is there who is going to put finger on those individuals who are the offenders, and ultimately they will get free from the from the hand of the law. Ultimately, our criminal justice system is that much weak and that much long process was over there. Finally, girl feel or the parents of the victim feels it's better to withdraw the case. It's better to do the compromise. So, I would like to say somehow our criminal justice system is responsible. It is, you can say it is organized crime, but I would like, my opinion is slightly different, because what we call organized crime is entirely different. But it seems that such type of offences are organized crime. But how it is unorganized? Because the moment they get the opportunity to commit the offence, at the very moment they commit the offence. Might be possible as they are the certain, in mind certain requirement and certain things are there in the mind, they want to do something, but they will not get the opportunity. This media, our television, it is also playing a vital role. And I would like to say, sometimes if we are talking about the friends, and recently one new phenomena about this living relationship, the legitimacy of the living relationship. When a female is misusing a law, it is also, weakening our legal system. Because if one time it has been proved that they have misused the law, the mindset of the majority of the individuals, it seems that they are using law as a weapon. They are not using law as a tool. So somehow, though it is slightly different with organized crime, but it seems. And second, so far as this gender biasness, it seems after this Amendment Act that they try to make it neutralized, but it is not like that. It is the opinion of the majority of the criminal jurists, and who have got a lot on the Indian criminal jurisprudence. Even I had interacted with a couple of individuals that the effort is not that much, practical that we can say yes, they have tried to make it utilized. Our Indian Penal Code has been criticized worldwide because we have a gender bias in Indian Penal Code at not at one time, at different point of time. And furthermore, we have different laws where gender biasness is over there. So far as sexual harassment at workplace is concerned, it is not like that only at workplace. There was one movie, and I have seen, I'm not habitual of watching the movie, I would like to share, but I have seen that movie only because of that. There was some, allegation on the male. I don't know what is the name of the movie, but Akshay Kumar and Kareena Kapoor. Ajnabi was the movie. So, our IPC is gender bias, and we have been criticized a lot because of this gender bias. And so far as the marital rate is concerned, we need to have certain judgments before this 2013 Act where everything has been elaborated in detail. But when we are writing in black and white, the work of the advocate to interpret the law, and at the time of interpretation of the law, just to remove the full stop and just to add the comma. And removal of the full stop and addition of the comma can change the entire story. One advocate who is fighting from the offender side, if you will ask that advocate, please stand from the victim side, the story will be entirely different. So, interpretation of the law and the authorities, and furthermore, the mindset, the personality of a judge. Personality of a judge matters a lot at the time of pronouncement of the judgment. So, when we are writing and giving the shape of one act, it means we are giving a space to our law luminaries or the legal professionals that they can use the law as a weapon or as a tool. So we do have and we have to accept the bottlenecks of the system, and we do have the bottlenecks. But whether we do have a leak-proof system, we do have a law which cannot be misused, I would like to say, and I would like to thank to Britishers. They developed IPC in 1960, and not that much. IPC has not been amended that much, and our Constitution of 1950, and that has been amended. And every day we are talking about the amendment of the Constitution of India. So what type of law we are developing, whether proper exercise and projective studies has been conducted, or we are developing our law after having the interest of couple of individuals. So we have to think even about those issues. Thank you.
Sir, one point about it. I think, sir, under Domestic Violence Act,
Even in IPC,
even in IPC, Domestic Violence Act,
and the gap. Again, here is a gap in our system. According to Domestic Violence Act, in every area there is we have to appoint protection officers, and I think only 2 or 3 states I have
2 or 3 states appointed domestic protection officers, and even in Delhi, in all areas, protection officers have not been appointed. And if any female approach them, then they believe to not take the complaint in a serious manner. And one time I personally discussed the issue with them, why this is so. They are saying that we are for the purpose of making the family, we don't want to break the family. ऐसा तो हो जाता है यार, right is there नहीं होती. This is the terminology they are using, the protection officers.
That's right, but that is a civil intervention.
No, these proceedings are similar proceedings.
There's no punishment, that's right.
No, punishments are similar and procedures are identical. Court will be a criminal court, investigation will be as the criminal proceedings, but so far as the relief is concerned, first relief, that relief is about the protection of the lady. That is about providing one accommodation, providing money and this and that. That is of the civil nature. At the same time, because the act is very new, even there are a couple of cases where conviction is there and they have been sent behind the bars. But only couple of the cases, majority of the cases, remedial, and afterwards victim feel that they have to do the compromise. And here I would like to say again that Domestic Violence Act has been misused a lot. Actually, Domestic Violence Act has not been, I have not seen 2 or 3 cases. I have gone through the cases and the judgment even from the Supreme Court of India. Couple of cases were over there where I have observed personally that the factual instances of violence was there. But in majority of the cases, it seems that the law has been misused. And so far as the Indian Domestic Violence Act is concerned, it is not that much strict and that much, not much good as Domestic Violence Act of different Western and European countries as they do have. But at the time of the fake cases, at the time of the malicious cases, they have the penalty. But over here, our act is silent. That is why fake cases are multiple times higher in comparison to the genuine cases. But the proceedings are criminal. It is written over there. The proceedings are criminal. I think your answer.
I think I just want to highlight some of those issues. One is that you are right that 98% are the family members, and the important reason being that especially the children, it is being said that one of the important component what we call is the grooming behavior. Now grooming behavior is something where the disclosure is delayed, to reduce the possible disclosure, and and there is no one will believe the child and so on. So the known person is always it's known to be a person who will commit a crime because for a number of factors, because the child will not reveal and he can play with the emotions of child and so on. That is why if you see some of the the recommendations are that we need to teach a child that what is a good touch, bad touch, okay touch, not okay touch, and so on, and it has to be inculcated from the school level itself, and I am aware of in Delhi there is one NGO, Baliga, they have produced a video, which also I have participated, about 10-minute video, which is shown to different schools where, to talk about that what is a good touch, bad touch, and so on. So I think it is important to understand that these things has to be there from the beginning itself, from the childhood to teach, because one of the important findings is of course that the majority, almost 90% of people who are known person. So the method should be that how one can prevent this, how they can, a child can avoid all those things. So perhaps the education, awareness and teaching some of the skills would be important, in that context. Another point you have raised very valid, that is, about the figures, because about that UNICEF study, I was reviewing the data. Of course, the African countries, when we were trying to analyze the data, it was almost more than 20% girls, whereas in India it was about 10%, but at the same time, we need to understand that the reporting is much less. Like our data comes from the NCRB, and we all know that NCRB, even for the suicide, it is very less because NCRB also reports many other crimes, including suicide. So there is underreporting in that. So if we take the data of almost 50%, then just imagine that what the percentage would be. Like 50% of ministry data, even the NGO data is almost 40%. So if you imagine that if this data is true, then the number would be very, very high. Maybe in the world, if you see that, then it would be not be lowest in the country. So the problem is that the reporting which comes from NCRB, which is much under-reporting, whereas the studies which have been done, which shows much higher, prevalence in that sense. So there is a discrepancy, there is a discordance. But yes, what we get data is from the NCRB.
I said at the time of the investigation, that proved that they are the part of the crime, but so far as the stranger is concerned, collection of the evidence became a bit hard and a bit difficult. That is why accused can save himself easily. Otherwise, according to the data of different NGO and international NGO, even the NGOs which are working for India, around 75 to 80% is for non-stranger and 20% is for the stranger, not with a view of the conviction, but for the purpose of commencement, that how they are involving in this sexual assault and like offensive. And NCRB, and I have had one discussion with one meeting of different police commissioners, and they have participated and they put it because it is a data which should not be recorded. And please switch off the recording for a second, please.
What is sexual contact? They don't know. So then about the family, if it's happening in the family, because child had to again go back to the family where the abuser is. Hardly there is under-reporting by the police officers. They don't report it, we discuss. So sometimes we wonder whether India is a democratic country or it's a diplomatic country. We were talking about the marital rape. Can you imagine when the lowest age of marriage is 18 years, but where is the chance of having a sexual contact with a wife with less than 15 years? Because you cannot marry below the age of 18 years. And for boys it's 21 years. So you stick to that law, stop the child marriages, and this definition will automatically be modified. And thirdly, regarding the commercial sex, everybody is silent about the commercial sex. This will be coming in the media. What is commercial sex? When Sita is there, the Suppression of Immoral Practice Act, you cannot have a sexual contact for the monetary benefit. So commercial sex is happening in India. They are silent about that. They are not ready to modify. Although the court has allowed the living in relationships, where a person, especially women, is staying with their wife. This is happening in Bombay with a police officer, staying with a husband for so many years. They are coming with a charge that he has sexually abused or he has raped. So the problem is arising with the living in arrangement. Yeah. So they are taking that particular part also into the picture. So we have to take overall view. Regarding the POXO also, I was wondering, why not in the act, why the medical officer? Anybody who comes to know about the sexual contact with the child is very safe, he directly reports to the police. Even child should be helped with the helplines that they can directly report. What is the best possibility? Schools, like Dr. Sagar has said, in school the children are to be sensitized, teachers have to be sensitized. When the child is reporting in the school, the school teacher or school authority, they should report to the police. Because that's the best solution. For child has two basically, either is the family or the school. Here, these problems are arising. So reporting can also improve. Once the thing. Then the problem Dr. Sagar has already highlighted is of the rehabilitation of these children who are the victims. So you don't have the rehabilitation facility. So they have to again go back to the same family. This problem arises. Because we are coming across the cases of child abuse where the mothers want that this should not be reported. This should not be reported. Because if they report it, our family life will be ruined. So what is the act which talk about the person? Because they usually insist it should not be reported. Although the child might be remaining in civil history. So all these factors are coming up in the picture, so that has to be modified according to that. And I think still India is in the process of the tip of the iceberg which has been reported. And regarding Dr. Gulwai already said, they were talking to one of the senior bureaucrats in the Ministry of Women and Child Welfare. He said they are going to call the petition for modifying the Domestic Violence Act and Dowry Act. Because they have been misused to a certain extent because the Supreme Court had also said they need to be modified.
And to identify two instances recently, it is becoming very practically difficult, impossible almost in both. Because both these instances, one was a young girl, she was raped repeatedly, by a friend, and she was admitted, found lying somewhere admitted in the hospital, private hospital. And the police was called, she reported the matter, all these things were done. Half an hour later, the mother went and reviewed the complaint. The girl was still there and she was later admitted with us. We went to investigate the person's case, we gave her ECP, they refused to report. So since the police report was made and I came to know later that complaint was withdrawn. Some of the cases who come to us as psychiatrists are much later with the consequences of rape. They come with depression, they come with, and in our history we get it. Well, we try to ask them in-house rape, relative rape. We say they like to report to the police, the patient ran away with the mother, ran away the same day. Now this, okay, to save our skin we report. And when the police come, I think law says that you should report and people report say. Then the mother came much later and I asked her why did you report? He said, Parivar band ho jayega. So this thing, we have to know, either are we teaching confidentiality, are we teaching all those aspects of our profession. They come to us after 3 months, 2 months. So what do we do in these sort of situations? And another thing I wanted to know is, this is the time for us to take some form of study for long-term consequences in our population.
No, absolutely right. In fact, this one, and and these are the grey areas, of course, which we need to understand. And that is why, if you see some of those, the process which is there, like it is that retraction is also part of, sometimes it happens. Like there are 5 stages which are being described, secrecy, helplessness, then accommodation, that is also important from then delayed disclosure, and finally retraction. So it happens because retraction can happen because child knows at time that they are the one who will provide the protection of the family. So that's there. But the important thing is, as per the law, yes, the reporting has to be there. Now, also we need to understand, for reporting, as a doctor need not inform the child or the parent. They can directly report to what they have to do. They have to report to the police station or SJPU, that is Special Juvenile Police Unit, and also the child line also they can report. So it's not that they have to inform a family, so they can also report in that way later. But of course, we understand there is a belief that there is a kind of grey area and perhaps it can create a difficult situation, but ultimately child has to be protected, and what is in the best interest of a child. So that one has to understand. So, but again, I think things are evolving, and because it is being thought that reporting will be important, because till now reporting was not taken place. Yes, rightly said that in recent times a lot of reporting has taken place. I think this is one of the factors, and perhaps I think some of the these the loose ends which are there, perhaps in time to come, I think they will be tightened up. So I fully agree with these, and people are aware of this fact. Just to respond to Professor Bhatia's comment about rehabilitation and some of those issues, I will just give my own experience. That at AIMS you were aware that some of the children had come, and we have talked to them, and we constituted a committee also at hospital.
You talked about the phenomena of implementation. I think in India still it's a problem to implement, because the role of media in sensitive cases should be restricted. Like in Western countries, they cannot report unless until they get a permission from the higher authority. They cannot report a sexual crime. They cannot report a attempted suicide, because they are part of the rehabilitation services. They are reported only when they are being asked to. Otherwise, they are not allowed. So that kind of ban should be there on the media also, because they are highlighting these cases where actually that may not be there. So they are putting this to one of the persons, like in Delhi, one of the husband had committed suicide, for he had been charged by the neighbor for sexual crime. So he committed suicide. So ultimately find out that he was not involved.
Also, what are the ways to be adopted for doing this type of work?
One thing I would like to ask you.
I'm going to narrate 2 patients whom I saw 20 years apart, one in 87 and one recently 2012. In 87, a lady came with her daughter with acute psychosis. She was admitted in a lady heart ward, and during the detailed history found that her elder sister had committed suicide and this girl was suffering. And from the mother we came to know that the father, they have 4 daughters, the father is a head constable and he is repeatedly raping all the 4 daughters. And when we told the mother that you go and report to the police, report, and so she said अगर हम report करेंगे एक तो किसी की शादी नहीं होगी, ये जेल में चले जाएंगे और पूरा परिवार भूखे मर जाएगा. That was way back in 87. In 2012, a girl came who was taking dancing tuitions. She came with somatoform disorder and lots of problems. Detailed history पता चला, her father, who was a leading politician in UP, he had been molesting her for a long time. She had left the house because whenever she tried to tell her mother, she starts scolding her कि इतना अच्छा मेरा career है, इतनी, and if you say this, पूरा career खराब हो जाएगा. So there are very social issues reporting to an media. So then there's another question to you as a lawyer. Like you said कि एक comma और एक full stop से lawyer बहुत कुछ बदल देता है. But suppose the person who is protecting the offender has a social obligation. If he knows that a person has committed crime, then should we take up a case to protect the offender? Should we refuse it outrightly?
So if an advocate is taking a case, he is taking a case of a individual. Nobody is aware whether he has committed a crime or not.
So many times they do know. And then
Many times they do know, but ultimately, so far as the factual situation is concerned, how they can refuse? Because professional ethics says, so far as the legal profession, we have to provide the legal services to everybody. And when we are talking about legal aid, and somebody is paying us for the legal services, we are not, you cannot say we are not trying to defend him in a way, in a legal manner, but we are taking the benefit of the bottlenecks of the legal system. So if they are the bottlenecks, not these, grassroots changes are required. And so far as the reporting is concerned, I think in last 1 month, reporting of such offences on the electronic media, that is on the marginal side. Because I came to know that some, direction has been given to the electronic media that such reporting should be minimized and should not be over there on the electronic media. So in last 1 month, if you can just remind, the reporting is on the marginal side. Another thing, so far as the rehabilitation of the juveniles are concerned, I am the member of one of the juvenile committee, and any case comes to the juvenile committee, we have to send the boy or the child to a rehabilitation center or to one NGO. Sorry to say, many of the members of the juvenile committee, they have their own NGOs. I am not going to the committee. Sometime I go when I found there is a crucial matter and I have to take my stand. Only that time I go, because otherwise they are making money like anything. So ultimately there are so many gaps and bottlenecks over there in the system, and we can try and we can raise the voice with the help of seminar, with the help of awareness program, with the help of articles. And so far as society is concerned, I would like to say that we do have a sleeping society, and the situation is alarming, and our educated society is more sleeping in comparison to uneducated society.
Sir, you please. Second row.
In the act of violence and sex, and what the second part was there, we are just evolved. Human beings are just evolved from the animal, and the sex is from the very primitive aspect of the brain. And but in law, we treat human beings as a monogamous or a polygamous.
Even the sexual offense is also taken as a form of aggression. Now aggression turned outwards, externally that becomes a rape or a murder or homicide and so on. And the aggression, when it's turned inwards, becomes a suicide, it's like that. And so, but there are some biological markers to it. And testosterone is, but again, these are all anecdotal because there is no kind of a perfect, biological basis to it. It does implicate testosterone in aggression and so on, but there is no hardcore evidence. There are anecdotal reports only there. So I think, yes, your point is right that one can assess. That is why it is sometimes seen higher in those who are involved in criminal activities and so on. So, but that's not a routine kind of investigation one orders for in the clinical practice of psychiatry.
To the girl who was scantily clad or probably pornographic movies or anything else, or to a stress or a trauma or anything. It's very easy to blame any situation, any event, any person for what we are going for. All of us undergo a lot of trauma, different types. All of us, I mean many of us might be watching pornographic movies and doing other things which have come into discussion. But still a very few try to commit rape. So is there any kind of, do the people who are accused of raping somebody or sexually abusing somebody, do they have a different neurocircuitry than the other people who are living in similar conditions but not doing it? Secondly, the person who gets abused after any kind of sexual act, does it change the neurocircuitry or makes him prone to have any kind of problem? Because number of people, because most of the studies which I read, with the sexual abuse, or especially childhood sexual abuse, they have been done with the patients who are already in a psychiatric illness. I did not find any single study where the intake was the persons with that sexual abuse and they were followed further.
Of course, kind of biological basis to understand offender of rape or for that matter person who homicide and so on. There are some belief, of course, which there are some evidence to it also. The rape as such, the offender is not just for the sexual gratification. It is much more than that. It will be too primitive to understand that it's just for the sexual gratification the rape is being committed. Now, for the offender, it is a kind of the masculinity, the kind of having a dominance, the kind of overpowering. So all these are important factors other than the sexual gratification. Now, this also, is one has to understand the context also, because on what basis the child, it is being said the one who has been molested in childhood, they are the one who can get offender also. If you see some of the research evidence which is there, that if you see the history of a person who is offender, you will immediately see that either they are from the chaotic family or dysfunctional family or parent discord in the parents, and some of the dysfunctional history they have, or most often they themselves have been the sufferer of that. So there are some bases to it, and even people have studied the kind of brain structure and so on. But again, it is not kind of a very hardcore evidence in terms of the biology. But there are some evidence, but we need to understand it's not just for the sexual gratification.
The sexual assault and the rape, then all the endospermic man and all the oligospermic man, those who are having hormonal imbalance and testicular atrophy, means they are not liable to commit the crime. So we are seeing the infertility patients and we are coming across, even when the rape cases are coming, there is no sperm, no motile sperm in the vagina or the area. Even then that is proved, the law is proved. That leads to this aggression in the behavior, but the sex lies is a mindset, is in the psyche of a man, and that, or in a female, that lies in the psyche of a person, male or female hardly matters. So psyche is not dependent upon the hormone. A youth who is having, where the hormonal imbalance is there, then there is aggression, and that's why we say that the channelization of energy is required of a youth, not for this purpose.
And we will be able to come to your mind. Now I must thank all of the colleagues, Dr. Mamta, Dr. Vaibhav, Dr. Purwal and Dr. Ajay Sagar for helping all of us to review. Thank you very much.
And we have made many new interconnections and major turmoil in our synapses. I thank you all, the esteemed panelists, to color this important issue with a rainbow of food of thought. I would like to invite our organizing chairman, Brigadier S. Darshnan, please give mementos to our panelists. Please. Dr. Rajesh Sagar. Subharti. Dr. Mamta.
Comes to the last talk of the scientific session, and last but not the least, it's on a very interesting topic, changing role of the psychiatrist today. I am an eminent guest speaking of psychiatry who needs no introduction. He is Director Professor, Department of Psychiatry, MAPSI, Delhi. I request you, sir, to kindly come on the dais and take your place as a chairperson. And our second chairperson, I request Dr. G.D. Kulwal, a senior consultant psychiatrist. Dr. Kulwal did his PG from SMS Medical College, Jodhpur, and is presently working as senior professor, Department of Psychiatry, SM Medical College, Jodhpur. He has 25 years of clinical, teaching, and administrative experience, and he has published many papers in national and international journals. I request you, sir, to kindly occupy your place as the chairperson of the dais.
Kulwal perform this ritual to their lesson, which is, I believe, is quite important, and that is the changing role of psychiatrists in today's scenario. If you look at the history of psychiatry and such, when did psychiatry start? First, the mental hospital came, which was made by the Inspector Generals of Police. It was only at the beginning of the last century that the medicalization of mental hospital took place. And the civil surgeon of the district was made in charge of the mental hospital of that particular. That's how the medical profession broke in. Subsequently, the psychiatrist became the medical superintendent, which was notoriously called as aliens. And the people who were looking after the patients there were called quadrant mental hospital. And from there you can make out what was the role of the psychiatrist over there at that point in time. Just to provide custodial care. So, beginning from custodial care to an expert to advise about the marriage, that which girl you should marry, which girl you should not marry, and what are the opinions about the rapes which are taking place. Whatever social phenomena takes place in the community, the media people come and contact the psychiatrist. Please tell what is your opinion about it. So with the passage of time, the role of psychiatrist has undergone a lot of changes, and well, ladies and gentlemen, a lot of water has flown to the Ganges since when psychiatrists took over the role to heal ailing mind, to provide relief to the social problem, is the subject matter to be discussed by Dr. Rajay Gupta. Rajay Gupta is a very well-known figure in the field of mental health. We happened to be together in PGI, and we shared our good and bad experiences together for more than 5 years. And we continue to be very good friends, and we generally exchange various issues related to mental health. I believe there can be no better person than him to tell about the changing role as he himself has witnessed for more than 3 decades what we had begun with and what we are today going to face. I invite Dr. Ravi to in this every day. And I will also request him to limit it to a minimum bare minimum time so that we are not deprived of our lunch for a long time. Thank you.
His life is very fast changing. If you focus on the topics what we have discussed today morning, we talk of the sexual assault, we talk of the smoking, we talk of the life in the different psychiatric disorders. We did not mention anything of the major psychiatric disorders which are taught in the medical schools and colleges. So that reflects the focus of our discussion, focus of our thought process has already changed. We have moved beyond the core psychiatry of psychiatric disorders to the issues which are being faced with the society at large and what is the role of the mental health professionals in dealing with those issues. So there are implications. If a young psychiatrist who is trained in today medical colleges has to deal with the issues, then he has to be trained in those issues. If somebody has to fly aeroplanes, he is not to be trained in getting the trains and the cars and the buses, then he has to learn how to fly the aeroplanes. So what roles the future psychiatrist from today onward has in the society, that is the way that young man has to be trained. So change is a part of life. If you see the surgery today, surgeons were trained for the open surgeries. But if you want a gallbladder surgery today, 99% patients will want a laparoscopic surgery. There was a open heart surgery, but people will prefer angioplasty. So everywhere in medicine, the change is evident. So change has to take place. Change cannot be prevented. That's the process of the evolution. That is the process of the nature. And the practice of psychiatry has tremendously changed. I was discussing with Dr. Purwal, when he took subject of psychiatry, it was an unwanted specialty. It was very difficult 30 years back to take psychiatry. First, you are ready to do it by your own parents, then your friends and relatives. Isko kya ho gaya hai? Isko samjhao. That was the concept in whole of the country. But the youngsters who are in psychiatry today, it is a demanding specialty. Even you find this is one specialty, the horizons are very fast expanding. So journey of a psychiatry as a specialty and the journey of the psychiatrists have gone together because they are so closely overlaid. If you see this diagram, it started from mental hospital psychiatry. Even before that, you see the history of psychiatry. Even today, every state, most of the states have their own mental hospitals. So those doctors who work in mental hospitals, the kind of the patients they deal, the problems they face, the issues they face are very different. We have to work in a mental hospital to understand what kind of the issues, the problems those mental health professionals are dealing with. You move to the general hospital psychiatry. It was a pioneer subject step in the country when the general hospitals started having the psychiatry units. They had exposure to the medical patients, the surgical patients, the psychosomatic processes. The whole learning was very different. From the general hospital psychiatry to move to the private clinics, the kind of the patients coming to the clinics today are very different. Only recently I had a boy of 21 years old, came first into the clinic. I said, Basu, what is the problem? He said, doctor, I have a patient of bipolar mood disorder. Like, are you taking a treatment? But no. Who told you you are a patient of bipolar mood disorder? He said, I have learned from the internet. I put my problems and I am sure this is a bipolar mood disorder. Every day patient will come in the clinic, you ask what is the problem. Except 4 दिन से नींद नहीं आ रही. To take a history, there is no problem. There is no social problem, there is no psychological stresses. and the person says 4 दिन से नींद नहीं आ रही. So the kind of patients which are visited in the private sector, the private clinics are very, very different. So patients going to the private clinic in Delhi, patients going to the AIMS OPD, patients going to the Shadra hospital are very different. There are different issues. Then you have community psychiatry, community clinics. Now you have counseling centers. In Ludhiana, one of the doctors opened a clinic with the name of Mind Plus Clinic. So we are naming the clinics the way we take the stigma from the clinics. Then you have rehab centers, then we have positive mental health centers, alternative therapies. So the gamut of the psychiatric disorders, the services is totally changing. So gradually, psychiatric services are not confined to the psychosis or psychiatric disorders, but they're going from illness to the issues. If you see all around you, like Dr. Dhruv has pointed, you see the TV channel where there is a discussion on any psychosocial issue. You'll see one of your colleagues sitting there and giving the prominent in everywhere. लड़का लड़की की क्लास के अंदर दोस्ती हो गई, and number of problems will start. दोस्ती टूट गई, the problem starts. You have a young boy in the clinic. She says the boy is asking for sex. He is demanding. He says मैं तो दोस्ती तोड़ दूंगा. जब दोस्ती टूट गई, again the girl and boy come in the clinic in a severe depression. They are suicidal. They want to end their life. They become aggressive. They become violent. It was not an illness. There was no illness. They are perfectly normal people. You see, everyday youngsters, those doctors who deal with the youngsters, they are unable to handle small little situations. Valentine Day, young boys and girls are very disturbed. अंकल मुझे एक बड़ा बेकार सा गिफ्ट मिला. मेरी सहेली को इतने अच्छे आज गिफ्ट मिले. मुझे क्या फ्रेंडशिप डे में छोटा सा बैंड मिल गया था का. And that causes such a severe amount of depression in the youngsters. They take much longer time to respond, to recover, and bounce back to normalcy. So small things. Only recently, I had a young girl. She was 17 years old, becoming aggressive in the home. When she was brought, she was not speaking. She was quite moved. The father said, "तुम घर में कह रहे थे अंकल से बात करूंगी, तुम तो बोलती क्यों नहीं हो?" Suddenly girl said, जब मम्मी पोर्नोग्राफी देखती है, it is normal. जब पापा पोर्नोग्राफी देखते हैं, it is normal. जब भैया पोर्नोग्राफी देखता है, उसको कोई कुछ नहीं कहता. जब मैं पोर्नोग्राफी देखती हूँ, why this issue in the family? She is right. What wrong she is saying? Every day you are telling everybody is equal. Every day you are telling you are just like a boy. So the issues which we are going to face today or tomorrow are going to be entirely different in the society. And then unfortunately, if there are issues today, there are nobody in the family where the people can talk. No other physician understands these issues. There is not a single surgeon, single physician. For them, it's a medical disorder. They treat a medical disorder, take a history, the patient is forgotten. It is only mental health professionals where people have access, they can discuss, they can talk of their problems and their issues. So today in the society, every issue in the society has become a mental health issue. If you see, patients come to the clinics, the small issues, and they tell, कि डॉक्टर से बात हम किससे करें? हम दोस्त से बात नहीं कर सकते, हम अपने फिजिशियन से बात नहीं कर सकते, हम फैमिली से बात नहीं कर सकते. So starting from the core disorders, we have come to the issues, small problems which the humanity is facing every day. So then, if you see very closely, we are dealing with the problems of the human suffering. If society is changing, society is progressing, there is more economic progress today, there are more issues. So issues do not solve once the poverty is gone. 20 years back I was thinking a lot of people, the problem will take care once we become more prosperous. When there is more money in the hands, because the financial issues are there. But as the prosperity is rising, every day you find in the clinic, the issues are linked to the prosperity. Ludhiana is one of the most prosperous cities in the country. We have 17 years old boys, 6 years old boys, हमें तो और भी चाहिए, हमें तो मर्द चाहिए. And if the parents do not provide, they hate their parents, they hate the grandparents, they hate the younger siblings, they become violent, become aggressive. So psychiatric disorders are manifestation of the physical, psychological, social, spiritual issues. So that is the widening issues which the psychiatrists are dealing today. So from a disease, we have found the problems, the issues, the personalities, the thoughts and feelings, the ethical issues known in the last few years in the country. You see the General Power one is gone. So this is very important to understand. We are not talking of illnesses. The psychiatric disorders or psychological disorders are linked with the human issues. They are linked with the human suffering. To start from the psychiatric disorder, you see people with the mental disequilibrium, they lose their balances because they have disturbed thoughts. Why somebody has become the rapist? Because there is a disturbed thought. There is a poor quality of emotions. So what is the state of the human mind? That decides the quality of the life and that decides the other issues. So it is not with the illness people come to us, it is a human suffering. You find a lot of people come to the clinics because they cannot cope up with the situation. They are normal situations, but the pressure is rising, the stress is rising all around us. That is why they cannot cope up and they seek for the mental health remedies. So this is a journey of a psychiatrist. See, all physicians, all professionals have a professional journey. You see, you are trained as a psychiatrist in a particular way. As gradually you realize, you become a psychologist. You are dealing with the emotions, the problem, the issues, you are talking about the social issues, you become a social worker. You go into the depth of the problems, you understand how the human mind works, how the unconscious mind works, you think you become a psychoanalyst. Gradually you find the patients coming to you, there are community issues, there are social issues at large. Then today, if you see 100 patients in a clinic, 10 to 15 are people who are 80 plus, 85 plus. And nobody has been taught how to deal with those problems. See, friendship problem. Once you become a parent, then you realize there are a number of friends. There are different number of classification of friends. There is a friend, there is a close friend, there is a real friend, there is a best friend. And now another movie is coming up, Chetan Bhagat, which deals with the different classification of the friendships. As a parents, as a therapist, you don't know what is this classification. So the kind of the changes which society is coming, that reflects in the clinic. Then you become a counselor yourself. This is the best psychiatrist is a counselor. Then you become a motivator. So journey of a psychiatrist is a from concrete to the sublime. This is how you understand the subject of the mental health. How you understand the processes. See, as you learn psychiatry, as you talk to the more and more people, you try to understand the problem, you become more curious, you are more human, you are more humble. You see, none of your colleagues understand the problem so much. You are more connected with the people. So this is all kind of qualities of the human behavior, the human problem, the human issues which come in your mind. I am just cut short. See, if you see the different classification, if you see in this room only, there are number of layers where the mental health is sitting. Dr. Roha is a guru of the gurus. Even his students have become the professors. So each person, where you are, that shows your mental abilities, your awareness, your capability and your exposure. So all of us, as we grow, we have different concepts, different practices, different thought processes. And our understanding of the subject, aware of the subject will also differ. So I have just two slides. See, for the last 3 to 4 years, what I started in Ludhiana is a caregiver meetings. What I realized was it is not possible to communicate end of the day to one-to-one patients. You have to educate, you have to connect with the larger audience. We have 3 to 4 meetings every year. In each meeting, for the main speakers. Then speakers come from the audience. This is 400 people. They're all my clinic patients. 13. Dr. Avasti was the chairperson. I was the speaker, the right hand. I was the speaker. Then there's something lower from PCI. Then there's something Chaudhary from this place. On the left side are the caregivers. So caregivers are put on this. And people listen, people participate with so much attention and the concern. In each program, at least 30 people come on the dais and talk of their experiences. The father of a patient who has a bipolar patient. She is a mother of a severe depression. She is a housewife, husband is a chronic schizophrenic. She is one of the important religious ladies in Punjab. She has a group and she is a patient of mood disorder, openly talking our experiences of depression, how the treatment helped her. So what you learn from the caregiver meetings is there is a better communication with family members. The questions arise are, should psychiatry be pigeonholed or liberated? Should we focus only on the core psychiatric disorders, or we should focus and discuss all other issues coming in the society today? I personally feel the second half. We should not confine to the core psychiatric issues only. Should psychiatry remain folded or unfolded state? Should psychiatrists themselves be the agent of the change, or will be the compelled to change themselves? And this is very relevant in the psychiatric training programs today. See, the most of the centers in the country, the training programs are 2 tools. One is the DSM-5 of 4 classifications, comprehensive psychiatry and sleep and stop. These are the 3 pillars where the psychiatric training is totally dependent. Whether the examination, the training program is depending on the comprehensive psychiatry, what is DSM-5, that is a national international issue, what is the DSM-4 and what sleep and stop says. But behind the issues which our PDs have to understand and handle, are they sufficiently being trained to handle those issues? Because if you are not trained, if you are not competent, then you have insecurities and other issues once you grow up. So this psychiatric training today is tuned with the changing issues, the changing responsibility, the changing role of a psychiatrist or not. That is the issue. And do we have the professional manpower, the infrastructure, resources to go for this stage? So can psychiatrists work only on the medical model, like our physicians are doing, or they should go out of the medical model? Like physician, should we talk of the pill for every ill? Thank you very much.
With this we can have a couple of quick questions if there are any. Any questions?
Like 1984 at Sept Mental Hospital. Right from that, 30 years after the Department of Psychiatry, Medical College, we have changed our roles in different ways. And finally, we are not confined to the only bookish psychiatrists or only for the psychiatric illnesses like schizophrenia, depression, or any psychosis like that. Now we have to play so many roles in this society, organizing camps, organizing community meetings, educating the people, giving the counseling to the youngsters, solving their such problems. We can say behavioral problems, not the mental problems actually. Many people come with different problems. अभी एक दिन कुछ दिन पहले एक लेडी आई, सब शादी हो गई है, 3 साल का बच्चा है, फेसबुक पे किसी फेक प्रोफाइल से उसका इंटरेक्शन हो गया और उससे नाउ शी वांट्स टू मैरी विद हिम. उसके पेरेंट्स लेके आए थे, उसको गाइड करो, काउंसिल करो, ठीक करो. Now this is the sort of role nowadays, not only the medicines, tablets or the CT either. So it's a very nice presentation by Dr. Rajiv Gupta and very burning issue and very interesting issue, you can say. because we have changed our role, but we have yet to change our role in next coming years. So thanks to Rajiv.
Thank you. Thank you so much, sir. Now, Dr. R.C. Jaloma. Thank you so much, sir. Dr. G.D. Kulwa. Thank you so much, sir. Thank you, sir, for doing the honor.
Practice by Dr. Rajesh Nagpal, who gave a very stimulating lecture on it, and I think the message was driven home very well to maintain the boundaries, particularly in your therapeutic relationships and various other aspects. He very comprehensively covered the topic. I'm grateful to him. This was followed by a very wonderful, comprehensive talk on recent advances in biology of OCD and its impact on clinical practice by Venugopal Jhawar, a senior consultant in psychiatry from Varanasi. He went through the whole gamut of the neurobiology, followed by correlating the neurobiology with the symptomatology, which is indeed another very good learning experience, not only for the residents, but for many of us. The third topic was very beautifully given by Dr. Subharti, assessment of children and adolescents with psychological problems. This topic was once earlier attempted, but we thought that it needed a repetition, and this time he dealt with it in such a systematic way. Most of us will not find it difficult to assess a child or adolescent. The way he put it across was so lucid and brilliant. Unfortunately, Dr. Vishal Sinha could not attend his own personal reasons, so that topic was to be cancelled. Today's topic, the highlight of today's topic were, there were really neglected issues in psychiatry. With most neglected issues, we have always been talking, like Dr. Sagar mentioned, for 2 or 3% of patients we spend 3 years. For the rest is left blank. We hardly communicate to our trainees. It's not sufficient importance is not given in the curriculum nor in the examination. We asked them all sorts of questions about schizophrenia, depression, OCD, and so on and so forth, which is commonly seen. As Dr. Rajiv Gupta, Dr. Rajiv Gupta had highlighted about the changing roles of psychiatrists and psychiatry, I think our topics had a lot of relevance. We need to be much more than treating a few disorders. We have a much bigger role to play, and these neglected topics, I am sure, would have sensitized our PGs and many of us to give these topics also sufficient importance, and we will insist on their curriculum when we are teaching or training or holding seminars. We will include such topics also, which was not there in the curriculum earlier. We started this morning with a beautiful talk by Dr. Ravi Gupta on evaluation management of chronic insomnia. It is very clear that very often we find quick solutions for anyone coming with complaints of sleeplessness, like giving him a sleeping pill or adding an antidepressant. I think that concept he has revised to a very large extent. Dr. Bhatia again gave a very detailed account about newer nutritional supplements in treating psychiatric patients, and the role of vitamins and other nutritional elements, the role of healthy food and healthy habits. It was a very important talk for all of us, and I am sure we have all benefited from it. The next talk was delivered maximum by me, by Dr. Ziloha. He was really driven home a very tough point for me. I personally take it as a very valuable talk, sir. And this talk, I have never heard it in any conference. I have attended many conferences. I have never heard such beautifully delivered, full of punch in it. The highlight of the day was our panel discussion on sexual abuse, sexual assault, very ably headed by Dr. Agarwal, HOD of Department of Forensic Medicine, University College of Medical Sciences, and his team of analysts. It generated a lot of discussion, and again, it underlined the need for us to be not only aware, we contribute our opinions and experiences to further improve the functioning of the laws as well as better care of the victims. I would rather call them survivors, not victims, because we should not use the word victim for a person who has survived, and give it a better term. Victimization means he is sick, the victim. This is my personal view. And we should try our best to remove the stigma attached to it and be actively involved in the counseling and therapy of such patients, even if they come late to us. Unfortunately, there was no postgraduate student who was willing to participate in the external competition. I feel sorry, we were ready with the topics, but nobody came forward even though it was announced. I hope next time we have a better response. As far as we have to declare the awards for in a minute. And in the meantime, I'll ask for comments. I know we had a lot of shortcomings. We will welcome shortcomings. Please tell us. Please be frank with us so that we can correct ourselves next time. We will not stop holding conferences. If there is any comment, kindly tell us. And I once more thank Dr. Shashira and the team for giving us this opportunity to host this conference.
Sir, I'd like 2 minutes of your time.
Pardon, ma'am?
I'll just speak for 2 minutes.
Dr. Sudarshan and Dr. Sandeep Chaudhary and all the members of the organizing committee who are here since yesterday and have done a hard work. Another important task which I have to do is to introduce the new office bearers of the IAPP. So the next president is Dr. Madhukar from Faizabad. He is not here because his kid was there. And the secretary is Dr. Vipul Tyagi. Our treasurer is Dr. Vipul Malhotra. Doctor is here for the new. And and another important announcement is that from this year onwards, we will be having a P.K. Chaturvedi Oration Award. Actually, late Dr. P.K. Chaturvedi, the senior psychiatrist from UP, who started this concept of IAPP UP. He was one of the founder members. So, and he passed away in 2007. So, in his name, we are starting an oration from the next year, which will be start from Faizabad. So, these are the two things.
This oration is for young psychiatrists?
No, sir. This oration is to be held annually at the annual IAPP conference. The oration will be awarded to a senior fellow with at least 10 years standing in the profession. The nomination has to be recommended by 2 senior fellows of the association, and the biodata consisting of personal, professional information, academic achievements, honor and award should be sent in duplicate to Chairperson Awards Committee, who is Dr. R.T. Manidu, and the other members of Awards Committee are Dr. Sarvesh Chandra and Dr. Ajay Puri. And then they decide, and every year this award will be given. And for the first time, we will be calling Dr. Puri's wife.
Okay.
This is what, and thanks a lot for once again for your hospitality and the academic fees.
Acknowledged with an award either in IBS or any body. We have a lot of regard for him, what he has done and what he has contributed. In fact, he is the father of psychiatry, Indian psychiatry.
So this award will be only for Subharti or this
It will be only for Subharti. We will take contributions if they are willing to contribute. Because a big amount is required for the corpus. But we will do it. We will do it. We got the permission. Only thing we need the permission from the family members. Family has to agree. So you call Dr. Chaudhary. Just want to announce the award.
He is there.
This conflict could happen. We would like to thank them in the form of a small token. I'll call out the name. Shikha. Thank you all for the contribution.
वो चेंज कर लेना ना बाद में. Yes.
Goes to Priyanka Chaudhary of MS.
सर थोड़ा
If there are any comments, no more comments, then I would like to say something.
This morning, I have enjoyed each and every session to its fullest extent. Topics chosen were very apt and indeed very appropriate to the topic, the neglected areas in psychiatry. And Dr. Sandeep Chaudhary and Lady Sudarshan indeed deserve highest appreciation for this very sacrifice they have for this academic activity. I convey my sincere thanks to both of them for providing this platform to all of us to interact in such an enriching academic way. I attended last night's social get-together as well. It was very enjoyable. We enjoyed it thoroughly. And today's academic as well as other elements were excellent. Dr. Chaudhary, Dr. Sudarshan and their team deserve heartfelt congratulations and our sincere thanks from all of us. I'm sure they will keep organizing this kind of wonderful programs in the future as well. Thank you very much.
Thank you, sir, for your very kind and warm words. And once again, we are grateful to all of you for your participation and sharing all your valuable time and sharing your experiences with us for this conference. I must thank all my colleagues, particularly Dr. Chaudhary, again, despite his tragedy, he has been always on the phone to help me. Dr. Supriya, Dr. Satish, the senior residents, Dr. Priyanka and Dr. Anubhav, and all the junior residents here, and the paramedical staff, the clinical psychologists, Mrs. Vasudha, Dr. Bharti, social workers, Solu and Vijendra, they all did a tremendous amount of work. Last but not least, we cannot forget Dr. Divya and Dr. Subharti for the amount of efforts they made in the conduct of the program. I don't know if they're gone. Thank you so much and goodbye.